Thank you for joining the 6th Annual Adventist Health Southern California Research Symposium. I am Dr. Neelam Patel, co-chair of the Adventist Health White Memorial Research and Publications Committee, alongside Dr. Soha Idris. We are so grateful that you have joined us today. This event is hosted by Adventist Health White Memorial and showcases the exceptional scholarly activities conducted by the medical nursing and pharmacy residents in the Southern California area, as well as our hospital associates who conduct evidence-based practice. Dr. Idris and I would like to thank KP Yelpaala, our keynote speaker, for joining us today and for sharing his insightful thoughts. We would also like to give special thanks to our White Memorial team led by Denise Miwagawa, Grace Hauser, and Yara Inamorado, who spent countless hours preparing for the event. Please enjoy the day.
I'm Chaplain Edgar, so let's have a word of prayer. Our loving Father, you are the source of all wisdom. Today, we praise your name because you have inspired and guided scientists in conducting research here at Adventist Health and throughout the world. Today, we ask for your presence in this symposium and your continued presence guiding future research held at White Memorial in our systems and in the world. In your name we pray, amen.
Well, good morning, everyone. I'm Dr. Wilmoth. I'm the program director for our OBGYN residency program at Adventist Health White Memorial. And we all are looking forward to the presentations by all the residents.
So I'm Betsy Oslin, fourth year OBGYN resident, and my project was entitled Pregnancy After Tubal Sterilization, Tubal Re-Anastomosis Surgery as an Efficacious Option for both patient and physician. And this was done by myself and Dr. Quintero and Dr. Thomas at Care Fertility, which is in Glendale, California. And obviously I'm here at White Memorial as well. So just to, as an overview of what we'll talk about today, I'll talk a little bit about the background, move on to the objective of the project, materials and methods, the results, conclusions, and finally the references. So we'll start with background. So as we know, many women undergo tubal sterilization as a means of permanent contraception. However, studies show that up to 14% of women ultimately do express regret at their decision to have had this done. Therefore, if these women do desire additional pregnancy after they had such a procedure done, they have two main options for having a natural pregnancy themselves. One of these would be a tubal re-anastomosis surgery, or a TR as we know it. Another option would be IVF, or in vitro fertilization. There is a committee opinion that concluded that there is good evidence supporting recommendation for TR surgery, but there are not a lot of physicians who are offering it as an option to patients, and many would skip straight to IVF instead. And some possible inhibiting factors for an implantation of TR may include cost, operative time, risk of complications, and unknown pregnancy outcomes. So the objective of our study, the purpose of the study that we did was to compare pregnancy outcomes between women who had had a previous tubal sterilization procedure, then subsequently underwent either the TR surgery or IVF procedure. And the cost to the patient, as well as the provider providing the procedures, as well as the surgical time needed to do the TR surgery, were additional parameters that were studied with us. So we'll move on to the materials and methods. So this study was a retrospective cohort study that compared the pregnancy outcomes between the two main groups of women, which were those who had the TR surgery and those who had IVF after a tubal sterilization procedure. And the women that were in this study were between the ages of 24 and 40, and they underwent either one of these procedures between March of 2014 and January of 2019. And all of these were performed by Dr. Quintero at Care Fertility in Glendale. And the same general technique were used for all patients, so there was no confounding factors with that. For instance, the TR surgery was done, as many of us know from working with Dr. Quintero, with a mini lap, and the uterus was exteriorized, and then the serosa and the muscularis were reapproximated using a single stitch. Inclusion criteria for the study was essentially what we talked about, and any of these women having had a previous tubal sterilization procedure. Exclusion criteria included women who had had a previous salpingectomy, additional known infertility factors, and those who we were unable to contact for follow-up for pregnancy outcomes. And a successful pregnancy outcome in this study was defined as any clinical intrauterine pregnancy. It did not mean that the pregnancy had to go to term or become a viable fetus. And the data was analyzed for statistical significance using the chi-squared test. So results of this study. There were 349 total women in the TR group of the study, and 220 of them fulfilled the criteria. And then in the IVF group, there was 24 women, and 827 of those fulfilled the criteria. Of those women that were studied, successful pregnancy was achieved in 27.9% of the total TR group and in 49.6% of the IVF group. However, we broke this down by age, and the age-adjusted pregnancy rates for the TR versus the IVF were as followed. So for less than 35 years old, there was 45.2% versus 53.2%. And that had a p-value of 0.233. For the 35 to 37-year-old range, there was 35.7% in the TR group and 45.6% in the IVF group with the following p-value. And then for the final age group was 38 to 40. And the difference there was 12.9% to 40.6%. And that p-value was quite low, as we see, and therefore statistically significant. Also, the average cost per successful pregnancy was around $7,000 for the TR group, whereas the IVF was around $18,000. So a large difference there. And just for additional information, the TR average operative time was around 68 minutes. So conclusions of the study. We determined that TR surgery has comparable pregnancy outcomes to IVF for women less than 37 years old in age. Furthermore, TR surgery is cost-effective for the patient, costing around $11,000 less on average than IVF. Additionally, for most IVF centers that have a surgical center accreditation already, startup costs for a TR program are nominal, supply and material costs are minimal, and there is no need to hire additional staff. So ultimately, we concluded that a successful TR program is beneficial to both patients and the practice providing the service. These are my references. Thank you.
Do you have any comment on the risk of ectopic in tubal reversals?
That's a really good question. I don't know the specific number, and that was not something that we saw in our patient population that we had follow-up with, but obviously that would be something to consider, because with IVF, very unlikely to have an ectopic versus with a TR, you have a higher chance of that because you have tubal trauma and like damage to the tube, where an ectopic could happen, but I don't know the exact percentages.
Yeah, because when Dr. Quintero or anybody counsels a patient to undergo the procedure, that would have to be mentioned as one of the risks, right?
Absolutely, yes.
So hopefully he would know what numbers he would counsel. Does anybody that's on the meeting know those numbers? I'm just curious, not that I have a tubal reversal that I'm planning, but just curious.
I'll look into it for you, Dr. Shaw, though. I don't know.
Dr. Woolmuth, do you know that risk out of curiosity?
Not for tubal
Re-Anastomosis, I'm sure that literature is easy to search.
Okay.
But of course, there are many variables to it, and those spurious factors need to be dissected. But needless to say, I think post-presentation, that would be an excellent search to have, and that is ectopics after re-anastomosis. Very easy to do. And I might suggest to Dr. Oslund to follow through on that lit search and get back to you.
I will report back.
Thank you.
Dr. Oslund,
Yes.
good morning.
Right.
I have a question, and it is related to the number of IVF cycles that on average, that it took for somebody to achieve pregnancy. Was that the $18,000 included in the cost? Because that sounds to me like maybe one cycle. And I'm just curious in terms of, what is the average number of IVF cycles it takes to achieve pregnancy versus, tubal re-anastomosis. Once it's done, obviously.
Right. That's a really good.
Nobody's counting, cost after the initial cost. So.
Right. So this was for a single cycle, but I think depending on, so many different other factors, many women would need multiple cycles. We didn't take that into consideration, but obviously that would up the cost, multiple and make it much more expensive. So something that definitely could be looked into and studied further for it.
What was the $18,000 representing then? One cycle?
Yeah.
Okay. With that success rate of 46 or however numbers those, pretty good. Okay.
Dr. Oslund, how did you select your tubal re-anastomosis patient candidates? Did you base it on the type of tubal sterilization they had, operative note descriptors? Obviously, they wouldn't be candidates if salpingectomy sterilization was done. Did you actually screen them in any fashion, or simply made an assessment intraoperatively?
So it was a retrospective study. So we had a list of all of the TRs that Dr. Quintero had done. And then if intraoperatively it was discovered that they had a previous salpingectomy, because, some women are unaware of what type of procedure they actually had done, they were excluded from the group. But otherwise, all the women, because Dr. Quintero had done all of these surgeries himself, we knew that they were all done the exact same way. We looked through old op reports, but they were all done the same way and done by him in the same place. So otherwise, they were pretty much standardized.
Great, thank you.
Betsy, it's Denegi. I got a question for you.
Yeah.
The analysis, was it a two-sided analysis or a one-sided analysis? Like, did you do this as more of like a non-inferiority, or did you do it as two-sided testing?
I don't follow.
Well, my point is that if you went over your numbers again and treated it as a non-inferiority test comparing TR to IVF, you get more power out of the same number of patients, and you might, and perhaps maybe the 35 to 37 or even the 35-year-old, you might start to see more significance if you did that.
Oh, interesting. Okay.
Yeah, because really all you care is TR worse than IVF. I mean, it's nice to find out if it's better, but you really only care if it's worse, and so you can get more bang for your buck that way.
Okay, good to know. Thank you.
Dr. Oslund, did you observe any of the actual, I mean, I know it was retrospective, but in your rotation, did you observe any tubal re-anastomosis?
Yeah, I assisted Dr. Quintero on quite a few of them during my time there.
Will you explain to us the technique and if you think this is something that, like, let's say as a generalist, I'm doing an open myomectomy and the patient wants tubal reversal, is this within my scope of practice as a generalist to do it at the same time?
Yeah, it's been a few years, but from what I recall, essentially we did a mini laparotomy, and then we exteriorized the uterus and the tubes, and we excised so say they had just a standard TL, essentially re-anastomosis the tubes and brought them back together with a 6-0 vicryl suture. And then later down the line, he would sometimes, perform additional testing to see if the tubes were patent.
Very good. I just got a pop-up message that we are within the final minute of questions. Are there any others? If not, and I don't hear any. If not, then thank you, Dr. Oslund, for your work and your wonderful insights on tubal re-anastomosis.
Thank you.
Thank you.
Good morning, I'm Martina DeBella, a fourth-year resident here at White Memorial Medical Center. I'm excited to present this research on trauma-informed care, preparing providers to care for pregnant women experiencing homelessness. I worked on this project with my colleagues who are listed below there, as well as our faculty mentors, Dr. Wilmoth from our Department of OBGYN and Dr. Borden from the Family Medicine department, as well as Dr. Maria Hayes Bautista, who was very instrumental with our project's completion, helping us with the statistics and the numbers. To start off, I'd like to share a little bit about our background and why we came to be so passionate about this project. So our interest in this topic was sparked by various patient interactions that we all experienced or observed with pregnant patients experiencing homelessness in our clinic or in our triage area. And we often found these interactions to be frustrating and challenging in many ways. And we saw this project as an opportunity to address healthcare disparity in our community and to hopefully help improve healthcare equity and outcomes. So in our background research for this project, we found staggering results as it relates to trauma and women experiencing homelessness. Over 90% of mothers who are experiencing homelessness report having experienced some form of trauma, domestic violence, or have a history of childhood abuse themselves. And from our research, but also from what we see day to day on the wards, we know that homelessness is associated with adverse health outcomes, including mental health outcomes, such as higher incidence of depression, post-traumatic stress disorder, and substance abuse. And if we think about the patients that we're studying in this patient population being homeless, having experienced trauma, and also being pregnant, which is especially vulnerable time in a woman's life, we can see how there's many social determinants of health at play in this one special group of patient population. So there is a lot for us to kind of delve in and study. We are proposing that providing care to women who are pregnant and homeless is very complex and requires a specialized set of skills and knowledge, specifically knowledge in the trauma-informed care principles. Now you guys might be asking yourself what trauma-informed care is, as we did before we embarked on this project. So the principles of trauma-informed care are summarized on this slide, and they can be easily remembered as the 4 R's. So realizing the widespread impact of trauma, recognizing the symptoms of trauma from our families and our patients, responding to it by integrating these trauma-informed care principles into our practices, such as our clinical exams and our history gathering, as well as everybody in the clinic and in the hospital also being aware of how this can come off when you're dealing with patients who have experienced trauma. And then the last R is resisting re-traumatization. So being aware of our actions and our words to avoid re-traumatizing patients who have had these experiences. And this is especially relevant to us as OBGYNs because a lot of our physical exams are often intrusive with the pelvic exam. So being mindful of, of patients who've had trauma and how that relates to our history taking and our pelvic exam. So this newfound knowledge sparked us to look inwards to our own residencies and address deficits that we noted in our educational programs. And as a group, we felt that we were not sufficiently exposed to training on trauma-informed care, and we felt that this made us underprepared to take on these challenges. So this led us to develop a training module on trauma-informed care to help providers learn about what it is and how we can apply it in practical ways to our clinical encounters, which are often pressed for time. So the training's purpose was to enhance health assessments and develop physician-patient communication skills and increase physician confidence and comfort level with trauma-informed care methods. So the methods of our study were as a virtual training, and it's centered around an interactive patient case. And it was a virtual training that we did for our colleagues, much like this over Zoom. The components of the training included strategies for the first visit, as well as subsequent visits and care on labor and delivery. And it touched on the power of verbal and nonverbal communication with providing trauma-informed care. And we went over the trauma-informed care principles like I did for you earlier. And the most important thing that makes it more relevant for us in our community is it allowed us to provide our colleagues with community resources for providers, which we had previously gathered from conversations with our social workers here at the hospital. And pre and post intervention surveys of our clinicians were performed using both closed-ended and open-ended questions, using a 5-point Likert scale for the closed-ended questions. And these questions were written to gauge baseline knowledge and readiness to utilize the skills learned from our presentation. So again, this is what I just said. Okay, so our results, the educational training was held for 10 OBGYN residents, 13 family medicine residents, and 8 faculty members from both programs. In the pre-survey, the majority of participants admitted to no previous training in trauma-informed care. And in the post-survey, there was increased familiarity with the epidemiology, the comfort level with screening for trauma, and knowledge regarding community resources. So as you can see from this graph, everything pre-survey, was about 20% to half 50%. And then that increase happened after our training, about to 80 to 90%. Obviously, one caveat here to mention is that there was some attrition, which impacts our results data. About 50% of family medicine providers filled out both surveys, and about 67% of OB providers completed both the pre and post survey. So as is the case with most survey type quality improvement projects, attrition does contribute to some of the data. So in our discussion and kind of summarization of things learned, we concluded that caring for patients who have experienced trauma requires specialized training, which should start in medical school and residency. And educational interventions may increase awareness of trauma and improve quality of care through patient experience-centered care and enhance cultural and social sensitivity. I also wanted to point out that there's been a recent release of ACOG Committee Opinion number 825, Caring for Patients Who Have Experienced Trauma. This just recently came out a few months ago, underscoring the importance of keeping trauma-informed care in mind when caring for all patients, because trauma is so prevalent that we have to ask all patients about it, and understanding how traumatic experiences can have long-term consequences on health outcomes, especially if these trauma-informed care principles are not used during patient encounters. And then in terms of next steps, continuation of development, improving resident curriculum for all specialties so that providers who are in training can have the appropriate tools necessary to care for these patients and to help better outcomes. Thank you.
Any questions for Dr. DiBella? Thank you so much.
I did want to mention we presented this research at the ACOG virtual meeting last month. So I'm glad that I was able to share it with you all as well.
How did that presentation go? Did you get
Well,
questions?
because of the virtual nature of it, it was more of a poster presentation, and we had pre-recorded little blurbs about each of the parts of our presentation. It wasn't necessarily an interactive like Q&A style. So that was unfortunate.
What ACOG document, was that a practice bulletin or a committee opinion?
Committee opinion.
Okay.
It just recently came out actually after we had already submitted all of our work. So it was very timely in terms of our topic of research, and something that I guess ACOG is also looking into.
Thank you. I will definitely get that.
Dr. DiBella, what percentage of our patient population here at White Memorial do you estimate fits into the category with previous trauma?
I think, I don't know that we have a lot of data on it, because the main thing to finding that out is us asking and kind of having those tough conversations with patients. So it's probably a lot higher than we think in terms of trauma and previous abuse. I think it's one of those things that we will know more once we feel more comfortable asking and delving into the tough situation.
We are doing the PHQ-9 screening though in our clinic, and do you have an idea of how many referrals and the number of patients through that program?
From just trauma-informed care? No, I'd have to ask Petra. That seems like a good kind of way to gauge how we're doing in our clinic.
Yeah, it seemed like it would be added to your data to report exactly what we're doing in our own clinic. I think that'd be interesting.
Yeah, thank you.
Yeah, Dr. DiBella, I have just some information through Petra. More than half of our patients report trauma. I remember even a recent segment population was at 60%. Trauma comes in various levels. The PHQ-9 itself does not measure trauma, but it is a screening for at risk. And then the positive screens go to Petra, and then she dissects it further as to the origins. And there is a very, very significant measurable trauma within our patient population that we serve. So this is a very timely topic. You obviously knew that because ACOG followed your research with that committee opinion and readily accepted your poster for national presentation. So really congratulations on some excellent work.
Thank you.
I got a pop-up that we are within the last minute of questions. Any others before we move on to Dr. Parks?
I have a question. We're still doing the CPSP in our office, right? The program, the perinatal education program that the state does. Lawrence, do you know, Dr. Spencer-Smith?
I believe we are still providing the service, but I think the number of participants has drastically decreased over time, particularly new return enrollees.
Well, I know that was another format in which the medical assistant spending the time with the patient, going into their home situation, their, just things that impact their care that we're often unaware of. The MAs would report to me the stories were rather, there is a lot of trauma. Let's just put it that way. So thank you, Dr. DiBella. That was excellent.
Thank you.
Yes,
Thank
and
you.
Thank you for increasing awareness for all members of the department to remain compassionate to those who are reactive because of trauma. And that will lead to improved health equity and manage the disparities because of it. So thanks again. And we're ready to move on to our next speaker.
I'm Caroline Parks. I'm an OBGYN resident, PGY4 at White Memorial. This is my project on cervical cerclage training simulation for residents. So for an introduction, cervical cerclage placement can be difficult to learn for residents who have limited operative experience, but it is a necessary skill as an OBGYN provider. And in residency, we often use training simulations to teach critical skills that are necessary as an OBGYN. For example, we have simulations for vaginal deliveries, for shoulder dystocia, for laparoscopic and robotic surgeries as well. So who gets a cerclage? People who have cervical insufficiency can be candidates for cerclage. So cervical insufficiency is painless cervical dilation leading to pregnancy loss in the second trimester. So there is a history indication for cerclage, and these would include people who have a history of a first or second trimester, a history of 1 second trimester pregnancy loss due to painless cervical dilation, or a history of a cerclage due to cervical insufficiency. Physical exam indicated would be painless cervical dilation in the second trimester of the current pregnancy. And ultrasound indicated would be a cervical length that is short, less than 25 millimeters before 24 weeks in the current pregnancy with a history of a prior preterm birth, less than 34 weeks. So this is a nice flow sheet that can be helpful for guiding management with cervical length screening. So when do you place a cerclage? So for a history indicated cerclage, you would place it between 13 to 14 weeks gestational age. A physical exam indicated cerclage would be placed before 24 weeks as it becomes indicated, and this is known as a rescue cerclage. An ultrasound indicated cerclage would be placed again when it's indicated based on surveillance sometime between 16 and 24 weeks. The instruments needed for a cerclage placement include a weighted speculum, a right angle retractor, a needle driver, a 5 millimeter Mrsa tape, and a free Mayo needle. So residents who participated in this training simulation created their own cervical cerclage model using a water bottle, a hair bun maker, and a 1/0 vicryl suture. So in order to place a McDonald cerclage, you need to first be able to identify the cervical vaginal junction. And then you insert the Mayo needle at 12 o'clock, and then you take 4 to 6 successive bites in a counterclockwise direction. You remove the Mayo needle, and then you tie the loose ends of the suture at 12 o'clock. So this is just a picture depicting the way in order you place a McDonald cervical cerclage. So results of this project, residents participated in the training simulation, and then they completed pre and post-session surveys. There were 8 residents total, 8 OBGYN residents who participated in the simulation. And overall, residents reported a decrease in need for further cerclage training, a decrease in the level of supervision required for placing a cerclage, an increase in their confidence in placing a cerclage, and an increase in their ability to teach cerclage placement post-simulation compared to pre-simulation. And all residents who participated either agreed or strongly agreed that this training simulation would be beneficial for future residents. So here are the demographic data for the residents who participated. And you'll notice that 3 residents had prior training in placing a cerclage, and the remaining 5 did not have any prior training in placing a cerclage. So the results were analyzed for 4 outcomes. I am confident in placing a cerclage. I need more training in placing a cerclage. I could teach someone else to place a cerclage in a clinical setting, and the level of supervision at which a resident is comfortable placing a cerclage. So again, the results are broken down into residents who had no prior experience with cerclage and residents who did have some prior experience with placing a cerclage. So for the need for further cerclage training, there was a decrease in the need as perceived by all residents who participated in the training session. There was also a decrease in the level of supervision needed to perform a cerclage. And residents felt an increase in confidence in placing cerclage after the training. And finally, residents also reported an increase in their ability to teach cerclage placement following the training. So cervical cerclage simulation can be a useful tool for residents in learning proper placement of cerclage for patients with cervical insufficiency. And the simulation greatly increased resident confidence in placing a cervical cerclage. And in particular, for the residents who had no prior experience, their confidence more than doubled post-simulation compared to pre-simulation. And the simulation also greatly increased residents' perception of their ability to teach cervical cerclage in a clinical setting, which is particularly important in a training program as residents take on more responsibility for teaching as they progress in their training. These are the references. Thank you.
Any questions for Dr. Park?
My question was, how did you simulate cervical dilatation in the training? And also, did you practice tying the sutures after they were placed?
So the cervical dilatation was represented by the hair donut, which naturally is constructed with a hole in the middle. So that was the dilatation of the cervix. And then after the sutures were placed, the residents did tie their knot inside of the vaginal canal as represented by the water bottle.
Caroline, that was, a clever design in terms of the space that we often run into. The one thing that anybody who's done a cerclage would likely agree with is the consistency of that cervix. I think Dr. Spencer-Smith mentioned the fact that if it's dilated, that's a challenge, but also it is not easy to drive that needle through cervical tissue. So the hair bun is good from a shape, but from a standpoint of texture or density, it's misleading, because if the needle went through as quickly as it would go through that would be great. So the dimensions in a bottle is, a good start, but I'm wondering if there's another round something that's a little more consistent with cervical tissue.
Yeah, I did consider other items, and surprisingly, it was actually difficult to, maybe not as much to drive the needle through, but to pull that Mrsa suture through this material was as difficult in the simulation as it is in real life. So that part was at least representative.
Thank you so much, Dr. Parks. That's, as Dr. Shaw said, very clever, but of course, every patient's anatomic individuality is taken into consideration, whether it's a short cervix, a long cervix, very dilated, or an encroaching bag. And of course, the ability to manage pulling Mrsa through with a proper vector pressure without laceration, avoiding vessels. A hair bun's great, but it doesn't have blood vessels, and we need to respect those. So it's certainly a very clever setup to help the motions, and attention to surgical individuality, of course, grows from there. So very nice work.
Yeah, it seems like also the emphasis from the simulation is really on the technique, not so much the consistency, because some of the patients might even have had prior cerclages with scarring and so forth. So that becomes even harder to simulate. But I think it does give the person learning an opportunity to think about the challenges.
I agree wholeheartedly, because when we do some of our other simulations, they're clearly not the same as a real pelvis, like the shoulder. And so maybe the actual efforts made are a little different, but the steps of being in that situation, even though the simulation doesn't look like the vagina and the cervix, can be very helpful, because I do think it makes the participant realize it's not like it looks in the book. So I commend you on, coming up with this. Good job.
Thank you.
Great. Well, thank you to all of the senior class on their fine work. And we wish you well in continuing your inquisitiveness and your intellectual curiosity in your future endeavors and in your practice. Thank you so much.
Hello, everyone. My name is Alex Minchon. I'm a first-year podiatry resident at White Memorial, and I have a case study of osteomyelitis and septic arthritis and a limb-threatening infection. So osteomyelitis is an infection localized to the bone, and septic arthritis is an infection localized to the joint. Both of these infections can occur as a result of contiguous spread of infection to and from adjacent tissue as a result of direct inoculation through trauma or surgery, as a result of hematogenous spread from other distant infected sites. With the absence of a wound, it's difficult to diagnose and treat, and may only be first identified by joint aspirate, which is the gold standard for diagnosis of septic arthritis. The infection can quickly and severely damage the cartilage and bone within the joint, hence prompt treatment is crucial. Treatment involves draining the joint with a needle or surgically, and antibiotics also are usually needed to treat the infection. So this was a 54-year-old male with a past medical history of diabetes, end-stage renal disease on hemodialysis, hypertension, hyperlipidemia, COPD, hypothyroidism, and a history of osteomyelitis with status post-partial fifth amputation on the right foot approximately 2 years ago. He was initially seen in the ED at 8 in the morning for severe sudden onset of intractable right ankle pain at rest, which began approximately 4 hours ago. He denied any trauma or open wounds or lacerations to the area. He denied any fevers, chills, nausea, vomiting, shortness of breath, chest pain, or abdominal pain. The patient was initially started on IV vancomycin and was given a 2-liter bolus in the ED. He was transitioned to IV meropenem, Zyvox, and Clinda within 4 hours from the time of admission. So there are some case reports of critically ill patients with septic joints secondary to hematogenous spread. These patients either had central catheters or UTI. Septic joints in these cases were a secondary event. However, in our patient, we had no urinary tract infection, no open wounds, and no central catheters. It is believed that the septic joint was the primary event in this case. That is supported by the extent of bone involvement and destruction noted on examination in the operating room. So initially, the patient's vital signs were pretty stable in the ED. He was mildly hypotensive, thus that's got the 2-liter bolus. His labs in the ED were notable for a white count, elevated white count of 17.1, elevated lactic acid, ESR, and CRP. His white count did shoot up to about 28.6, 4 to 6 hours, about 4 hours after he presented as well, because we got a repeat CBC. So on physical exam, he had severe tenderness to the palpation of the right ankle joint. Pain was elicited with ankle joint range of motion. There was no crepitus appreciated, and he was unable to passively perform range of motion. On derm exam, his right ankle was mildly worm edematous and erythematous. There was no tracking, and there was no open lesions or lacerations. He was neurovascularly intact. So in this case, radiographs really provide no benefit when trying to evaluate for septic arthritis. MRI is pretty useful for septic versus non-inflammatory type arthritises. However, in this case, the patient did have a pacemaker, and we were unable to figure out what the model of the pacemaker was and if it was compatible with an MRI, since this was over the weekend. But the gold standard is joint aspirate in these cases for joint fluid analysis. So initially, this is what his clinical foot like in the ED. You could tell that the right ankle, pretty localized to that right ankle, it was a little bit of swelling, but as you could appreciate, there's no open lesions, lacerations, there's no really signs of infection in this case. So we decided to, just protocol, get some x-rays. Like I said, really there's no benefit. And looking at this AP and lateral view of the ankles, really we couldn't appreciate any soft tissue infection or any osseous involvement. So we decided to do the next best thing, and we decided to get a CT scan. The CT scan was also kind of questionable, and the CT scan, we looked through it, and there was a questionable area around the subtalar joint, the calcaneocuboid joint, with maybe a pocket of a pus pocket laterally. So initial treatment and plan, we decided to take the patient into the operating room, and we started the patient. The first thing we did, we tapped his ankle joint, which was negative. Just clear joint fluid was aspirated from the ankle joint. And then we followed, what the CT scan said, and we decided to open up the patient on the lateral side. So here's a picture of the operating room. So initially when we made this, we made a small incision on the lateral aspect of the ankle, and everything looked pretty good and healthy. But we decided to, dissect a little deeper. And once we got into the joint space, we were surprised that he actually had, purulence or pus in that calcaneocuboid, the subtalar joint, and the talonavicular joint, which is, I've never seen it, but a pretty odd place to have septic arthritis or pus within that joint. But the ankle joint was clean. And then according to the CT scan, there was also possible pus pocket tracking proximally along the perineal tendon. And you can see on this left bottom image with this forceps, this is the perineal tendons. And there was about like 10 cc's of pus tracking proximally along the tendon sheet. But within the joint space, there was about 10 to 15 cc's of purulence within each of those joint spaces. And as you could see in this image, this is the talus and the calcaneus. The bone had this brown discoloration, which was clearly an indication of that this was infected. So we did take cultures in the operating room. We got bone cultures as well. Post-operatively, his white count started downtrending and had normalized by day number 3 or day number 4, but he was also bacteremic with MSSA. Cultures came back with staph within the wound, and bone cultures did come back positive for osteomyelitis. This is an image of, I think, the second post-operative day. However, this patient did require multiple successive washouts of this foot. So, like I said, we did further extensive washout and debridements were performed on the patient, and despite the antibiotics and drainage, his joint remained purulent and appeared to have significant residual infection and inflammation, requiring successive washouts. So in conclusion, with the absence of a wound, it's difficult to diagnose, treat, and recognize septic joints, especially for inexperienced clinicians. However, the infection can quickly and severely damage the cartilage and bone within the joint. Hence, prompt treatment is crucial. We therefore encourage clinicians and surgeons to have a high index of suspicion and a pretty low threshold for tapping a joint if they suspect septic arthritis for this condition, especially with the high incidence of limb loss in this aggressive infection. And that is it. Thank you, everyone.
So I'm Ivana, one of the podiatry residents second year. And I'm presenting this case study with Dr. Banks and Dr. Mathis. This is the surgical excision of an acquired epidermal dysplasia verruciformis in an HIV-infected patient, which is a rare case study. So some background about this deformity. It's called, it's also known as Treeman Syndrome. It's an extremely rare autosomal recessive hereditary skin disorder. It's it's highly associated with squamous cell carcinoma. It's characterized by abnormal susceptibility to HPV of the skin. It's typically caused by HPV types 5 and 8, which shows increased expression in specific genes and biomarkers, including a list of these as represented by one of the studies that I found. It presents typically with hypo or hyperpigmented macular lesions, versicolor-like lesions, and an early tendency to transform into skin cancer. So it's a lifetime disorder of cell-mediated immunity, has no preference for any specific sex, race, or geographic area. It can be sporadic or familial. The familial form is more common. However, in our case study, it was sporadic because there was no family history of this disease known by the patient. It is usually seen in immunocompromised patients following renal transplantation and Hodgkin's disease, and also in patients with SLE, lupus, and also in patients with HIV, which our patient did have or does have. So presenting this case, he's a 38-year-old male, HIV positive with diabetes as well. He's complaining about these painful multiform lesions over the entire plantar surface of his bilateral feet. He's had this since childhood. It kind of, it appears as flat, wart-like brown plaques. He's been treated for years in the podiatry clinic with routine debridement for these congenital calluses. And he did not have any other treatment past that. He just had regular routine debridements in clinic. No similar complaints in the family, otherwise healthy. On physical exam, no other abnormalities there. However, these lesions just kept enlarging and developing, eventually encompassing most of his weight-bearing surface of his feet, and thus just severely limiting his daily life. I think at this time we were not looking at this diagnosis of EV, and then however we did, so you can see in the images here what it looked like before the surgery. So you can see that it pretty much encompasses the entire plantar surface of his both feet, and then you can see the thickness of it there on the lateral images as well. Extremely painful to be walking on this, just severely limiting daily life. So our treatment at the time was, since he had failed these regular debridements in clinic and that they would always recur, the treatment at the time was decided to be a surgical excision for a more deeper excision. So following anesthesia, we did a blunt dissection of these lesions to the level of the superficial dermis. The dissected layer was like clearly defined. And then on the left foot, we did debride a little bit deeper, which created a small wound to the subcutaneous layer. To this area, a urinary bladder matrix graft was applied to the wound. So results and post-op. So the culture that we took from intra-op on the right foot came back as Strep A galactiae and some fungus, Trichophyton rubrum. On the left, it was Staph aureus and also Trichophyton rubrum. The pathology, I went over to the pathology lab and looked over the samples with them. Unfortunately, our sample was not deep enough. What we got was just epidermis, and it would have been better to see more of the dermis layer itself. Follow-up. So these are the post-op status post 2 months after the surgical debridement. Unfortunately, they did recur, as you can see. It was at this time that we had kind of looked more into this EV diagnosis and was thinking that maybe this patient has this based off the clinical image. We referred the patient to dermatology, and the patient refused to go and is still not gone despite our recommendations to do so. And he's just happy with these regular debridements with podiatry. We're also still pending a full immunological workup. We were looking at immunoglobulin levels, complement levels, also a CD4 count for him as well. So, and you can kind of see here where that wound was, where we applied that graft. So the callus just like grew right over it. So our proposed treatment course from this time forward is, if we are to consider another surgical treatment, we would recommend something that in a case study that I found regarding epidermal dysplasia verruciformis by Fong, we would recommend maybe a deeper debridement, this time down to the level of the dermis, and cauterizing with the Bovie, with the bipolar electrocoagulator, areas where it's deep enough, and also get a deeper sample for pathology to look at and to see if it, if they can make that diagnosis from the pathology sample, the deeper level. If we were to see that, we would hope to see these enlarged keratinocytes in the upper epidermis with this gray-blue cytoplasm. And then also sending these for HPV detection and typing. We would also recommend isotretinoin for 7 months with dermatology. So in discussion, there's no permanent cure of EV achieved by any therapy at present. There's no really studies that give this specific regimen for treatment at this time. Other described treatments include cryotherapy, imiquimab, 5-FU, 5-fluorouracil, retinoids, and etc. And so we kind of just have to, we'll have to keep you updated on how this patient does and what treatments we try and kind of how this patient does. There's also not much evidence for EV specifically in HIV patients, even though it is well recorded to be in HIV patients. So that would be something interesting to follow up on as well. So that is my study. If anyone has any questions.
Dr. Kenwood, I don't see any questions from the audience.
Okay. Well, thank you for your time, everyone.
So again, I'd like to thank Dr. Geminelli Banks, who's our faculty for the podiatry department at White Memorial. And our next residency program is the Adventist Health White Memorial Pharmacy Residency under Dr. Tao Nguyen as the Director of Pharmacy. And we'd like to thank him for guiding his residents, along with Dr. Maria Hayes Bautista, who has given significant support to the pharmacy residents in their presentations. Our first presentation this morning is from Dr. Jennifer Chen on the impact of Pro-Calcitonin and Mrsa nasal PCRs, protocol on inpatient antibiotic usage in patients admitted for sepsis or lower respiratory tract infections. Dr. Chen.
Hi, thank you so much, Michael. I hope everyone can hear me okay. And first and foremost, I just want to say thank you again for Michael and Dr. Hayes Bautista's guidance throughout this project. So as mentioned, my project is on the impact of Pro-Calcitonin and Mrsa nasal PCR protocol on inpatient antibiotic usage in patients specifically admitted for sepsis or lower respiratory tract infections. So here is a brief table of contents of the topics we will be covering today. Some introduction and background of my project. So this is a quality improvement project aiming to target the approximately 30% overuse of antibiotic use days that are examined in general in patient. And this is accomplished through antimicrobial stewardship programs, which our hospital has a robust program for. Pro-calcitonin levels can help differentiate between viral and bacterial infections. They serve as an adjunct to clinical judgment, so they can be used to discontinue or simply de-escalate antibiotics for the treatment of lower respiratory tract infections or sepsis. And additionally, we also have another component to the project that is Mrsa nasal PCR assay. It has a negative predicted value of 99.2%. So we have also been using that in the setting of lower respiratory tract infections to rule out a Mrsa etiology and potentially decrease Mrsa covering agent use. So the objective of this study is to decrease unnecessary antibiotic usage through a system-approved Pro-Calcitonin and Mrsa nasal PCR-driven protocol through the ASP team at Adventist Health White Memorial. Our population includes patients that were identified through our pharmacovigilance platform, Vigilance. So these patients were all receiving antibiotics with the indications of sepsis and/or lower respiratory tract infections. All patients were greater than the age of 18. They were COVID-19 PCR negative. They are not immunosuppressed or immunocompromised, and they did not have cystic fibrosis. So as a breakdown of the population we included, I've separated this into two parts. So for Pro-Calcitonin part of the data collection, there were 72 patients identified with these suspected infections. 20 of those were excluded. 17 were actually discharged before the follow-up Pro-Calcitonin was ordered. One patient had actually passed away, and 2 of the patients were COVID positive. So the utility of Pro-Calcitonin is not entirely clear in the setting of COVID. So that's a reason that we excluded those patients. So that leaves us with 52 patients included for analysis. On the other side of this project, we also had the Mrsa Pcr data. So we had 27 patients with suspected lower respiratory tract infections receiving Mrsa covering agents who were assessed. 5 of these patients were excluded due to their test results being unavailable. And this could be for a number of reasons. The test actually takes a couple of days to come back. So sometimes the test results simply weren't available for assessment before discharge. And so this leaves us with 20 patients included for analysis. Again, this is a quality improvement project, and we used a system-approved protocol for implementation. And there was documentation of pharmacist recommendations in Vigilance, again, which is the clinical surveillance platform. So for the PCT portion, baseline PCT is drawn with antibiotic initiation, and then follow-up PCT is drawn 48 to 72 hours later, and results determine the recommendation. So there's different thresholds between lower respiratory tract infections and sepsis. For lower respiratory tract infections, we recommend antibiotic discontinuation or potentially de-escalation at a threshold of less than 0.25 micrograms per liter, as this could indicate that the infection is not bacterial in etiology. For sepsis, the threshold is a bit higher and requires a Pro-Calcitonin of less than 0.5 micrograms per liter. And similarly, it would encourage antibiotic discontinuation or de-escalation. Pro-Calcitonins that are greater than both of these thresholds could indicate that there actually is a bacterial etiology that needs to be treated with antibiotics. So on the flip side, for Mrsa nasal PCR, the assay is ordered for patients receiving Mrsa covering antibiotics for empiric lower respiratory tract infection treatment. So this could be for community-acquired pneumonia, hospital-acquired pneumonia, or ventilator-acquired pneumonia. A negative Mrsa nasal PCR result encourages discontinuation of Mrsa coverage because, as we mentioned, there is a negative predictive value of about 99%. So in our results, again, this is the Pro-Calcitonin side. So some patients have multiple Pro-Calcitonins measured at follow-up, whereas there's always just one baseline Pro-Calcitonin. So that explains why 54% of the Pro-Calcitonins in general were follow-up versus the 45% for baseline. And remember that interventions were only encouraged based on the follow-up Pro-Calcitonin, not on the baseline. So from the Pro-Calcitonin data for sepsis and lower respiratory tract infection, the duration of therapy was actually significantly shorter for accepted interventions versus bypassed interventions. So based on the protocol, pharmacists would decide if a Pro-Calcitonin reached the threshold as defined earlier, as well as the overall clinical picture based on chart review. Those two decisions would then lead to a recommendation of either de-escalation or discontinuation. So in those that the pharmacist recommended discontinuation or de-escalation, the average antibiotic use days were 5.5 compared to those where the recommendations were actually bypassed by the physician. The duration was 9.64, and this was statistically significant. So in terms of breakdown of the recommendations by type, there were 24 recommendations that were accepted from the pharmacist to the physician, and then 11 of those were bypassed. And the reasons for bypass include clinical deterioration, hemodynamic instability, or other reasons. So some of the other reasons included if cellulitis was in the differential and we wanted to cover regardless, despite Pro-Calcitonin, or if we needed to rule out some other infectious etiology. And so for Mrsa Pcr, there were 22 results recorded with lower respiratory tract infections, and 20 led to recommendations being made because the other 2 were actually excluded. So 1 was positive for Mrsa colonization, so there was no action taken. And 1 was negative, but similarly, as I mentioned earlier, cellulitis was in the differential. So the nasal PCR doesn't have utility in the setting of cellulitis. So the average duration of therapy was significantly shorter, once again, for those that had accepted interventions of antibiotic discontinuation or de-escalation. For those that were accepted, the use days were 2.6 versus bypassed had 11. So again, as a picture, accepted, there were 15, and bypassed, there was 5. So with the protocol, average antibiotic treatment duration was within guideline recommendations. Significantly shorter treatment was seen with interventions that were accepted versus those that were bypassed, using both the Pro-Calcitonin as well as the Mrsa nasal PCR protocol, which both were statistically significant. So based on trending PCT, 69% of pharmacist interventions were accepted by physicians. And based on Mrsa nasal PCR results, 75% of recommendations were accepted by physicians. And here are my references. So I'm not sure if we have time for questions, but I would gladly be able to answer anything through email as well. And thank you so much for having me today.
Dr. Chen, thank you very much for your presentation. Our next presentation is from Dr. Mrsa from the pharmacy, the assessment of an effective thromboprophylaxis dosing in COVID-19 patients. Dr. Mrsa.
So it's well known that COVID positive patients experience higher levels of inflammatory markers. This includes C-reactive protein and also the D-dimer, which is the coagulation marker. There is a need for higher thromboprophylaxis dosing in these high-risk patients, including COVID-19 positive patients. From the hospital database, we found that there were 15 cases of VTE incidents, so venous thromboembolism. These were identified from January to September of 2020. And from these results, 46% of those patients were COVID positive. So this indicates that there is that need for a higher thromboprophylaxis dosing regimen in these patient populations. So most of those patients did receive the appropriate VT prophylaxis with the regular guideline-derived enoxaparin 40 milligrams sub-Q daily or heparin sub-Q as well. But even though that they receive those adequate dosing for VT prophylaxis, they did experience those VT events. So we reviewed 5 protocols and guidelines to determine what can possibly be an appropriate VT prophylaxis regimen for these higher risk patient groups. We also reviewed the AH System VT Prophylaxis Advisor. This one recommends a twice daily low molecular weight dosing regimen to be more protective. So this is usually for orthopedic patients and higher risk patients, but it does recommend switching patients from heparin to low molecular weight heparin twice daily. So my project was a quality improvement project. Objective is to implement the AH System VT Prophylaxis Dosing Advisor for all newly admitted COVID-19 positive patients at Adventist Health White Memorial. As far as my methods, we did use the system approved advisor that was an implementation. Patients on unfractionated heparin were switched to low molecular weight heparin. As I mentioned, low molecular weight heparin is more effective in these higher risk patients. Patients on enoxaparin 40 milligrams sub-Q daily switched to 30 milligrams twice daily dosing. Obviously, if patient was renally impaired, we adjusted the dose. And patients were identified through the institution's electronic records, Cerner, Power Chart, and Vigilance. So the advisor was introduced November to December of 2020. So I looked at the patients, the COVID positive patients during that time and compared it to the post-advisor implementation. So it was implemented in January, and then our post-advisor implementation data was from February 2021. So we compared the pharmacist compliance of the advisor implementation and also the number of VT events from those two time periods as well. Okay, so for my results, 109 COVID positive patients received unfractionated heparin or low molecular weight heparin in November of 2020. So this is the pre-advisor implementation, and 87.2% of those patients received enoxaparin for thromboprophylaxis. So our main focus is enoxaparin. And then for comparing to the post-advisor implementation, so the 67 COVID positive patients received unfractionated heparin or low molecular weight heparin, and 82.1% of COVID positive patients received enoxaparin for thromboprophylaxis. So obviously we had a less amount of patients in this time period. And then I also looked at the VT events in November, compared it to February. So 4.6% or 5 out of 109 patients experienced a VT event, and 3 out of those 5 patients had that event within 48 hours. And 2 out of those 5 patients had a VT event upon admission. So obviously from 15 cases when they advised, when we were looking at all these cases, and then 5 patients after a minor introduction of the advisor. So we did see an improvement in that. And then for February, similar data, 5 out of the 67 patients, and 4 out of those 5 experienced a VT event 48 hours upon admission. And then we also looked at the appropriateness of initial VT thromboprophylaxis. So this is basically pharmacist compliance with the advisor implementation. So 74.3% of those COVID positive patients received the appropriate thromboprophylaxis within 48 hours of admission. This isn't my November data. There was one bleeding event that was documented after the dose was adjusted, and 90.5% received enoxaparin twice daily after the pharmacist intervened. As far as February, a little increase, so 83.6% received appropriate thromboprophylaxis after the advisor was implemented, 1 bleeding again, and then 90.9% of patients received enoxaparin twice daily after the pharmacist intervention. So this is just a little image from the VT task force from Apurva. So in January, we had 2 events. So this is during when the advisor was implemented. And then in February, our numbers increased a little bit to 5, but with more compliance and just monitoring the patients, we have seen a downtrend. So in March, we only had 1 VT event. So these were medical VT events. And then again, for our compliance, it has been improving as well. In conclusion, 74.3% of COVID positive patients receive VT prophylaxis with either low molecular weight heparin or unfractionated heparin when the advisor was introduced, compared to 83.6% when the advisor was implemented. So obviously we did see an increase in compliance, and more patients experience a VT event very early upon admission. So this indicates that we might have to be a little bit more aggressive when we approach these patients for VT prophylaxis. not therapeutic, but close to possibly therapeutic dosing. And from those 15 cases, we did see a decreased amount of VT events following the introduction of the advisor. And my references, and that's it. Thank you so much.
So Dr. Mrsa, thank you very much for your presentation. I don't see any questions in the chat, but if we do get any, we will forward them to you to be answered.
Perfect, thank you.
So thank you very much again for your presentation. Our final pharmacy resident presentation is from Dr. Kelly Tran, optimizing heart failure drug therapies to reduce hospital admissions. Dr. Tran?
Hey, hi, yes. My name is Kelly and I'm a PGY1 pharmacy resident. And again, my project is optimizing heart failure drug therapies to reduce hospital readmission. So I'll just be going over the goal of this project is to see the role of pharmacy resident facilitation, working collaboratively with the medical team and also cardiologists in addition to the clinical pharmacists to hopefully reduce hospital readmission rates for these patients. And through this project, hopefully we will be able to implement the heart failure management workflow process into daily clinical pharmacist tasks. So a little background about heart failure. So you can see here that heart failure is a huge problem in the US and it has a huge financial burden costing about $30.7 billion just in 2012. So this is one of the leading reasons that patients are re-hospitalized. And just looking at the AHWM heart failure readmission rate back in 2019, it was 20.3%, and last year it was 17.7%. So you can see here there's a decrease in last year's number, but only because less people were seeking emergency care because of COVID. So my project is a quality improvement project. Here we're looking at high-risk readmission criteria adults who are 18 years and over with a diagnosis of congestive heart failure. So an EF of less than 35% with an NYHA functional class of 324. So there's 3 points in care that we're really focusing on. At admission, making sure that we compile an accurate medication list for these patients, inpatient medication reconciliation, and then also at the point of discharge. So at the admission, we're gonna look through 2 of the system surveillance systems that we have here. So the clinical pharmacist work list through Cerner and the vigilance screening, that's where we will be pulling our patients. And with the help of interns and pharmacy students, they will be obtaining an accurate home medication list of the patient. After a medication list is obtained, the pharmacist will review for appropriateness of therapy and propose any intervention to the medical team and cardiologist. And before the patient is discharged home, again, the clinical pharmacist will review the medication list for appropriateness and any gaps in therapy and forward any interventions necessary to the medical team and the cardiologist. So this pharmacist workflow process is adopted from the 2017 ACC AHA focus update for the guidelines for the management of heart failure, with the addition of ivabradine, SGLT2 inhibitor, IV iron therapy, and sacubitril valsartan or Entresto. So this is the criteria of use and the indications of when to use these certain medications. So the outcomes that I will be looking at is the percentage of patients on guideline-directed medical therapy for congestive heart failure, the number of pharmacy-driven interventions, and also the number of time that a physician followed through or accepted the clinical pharmacist's recommendation for Entresto, ivabradine, the SGLT2 inhibitor, empagliflozin or Jardiance, and IV iron therapy. So this is the baseline characteristics of the patients. So we have a total of 75 patients that were screened. That you can see here that they are all pretty middle age, mostly males. Not surprisingly, we have a wide Hispanic population here in this area. Comorbidities, hypertension, diabetes, hyperlipidemia, those are the top three. The length of stay was just a few days less than a week. Average EF was 28.7%. And I just included other vital signs and laboratory values. In addition to that, it's noteworthy to note that as you can see from the hemoglobin, that a lot of these patients present with anemia, and they, according to the ferritin and the TSAT value, these patients have low iron stores. So the number of patients on guideline-directed medical therapy at admission was about half, and then at discharge, with the help of the clinical pharmacist and also collaboration with the physicians, at discharge there was a total of 58. So the total number of accepted heart failure therapy optimization came out to 33, and about a third was from empagliflozin, another third was from IV iron, and a third was from Entresto. And there was no interventions made for ivabradine. But as you can see from the table, about 50% or a little less were accepted. So you can see that the recommendations were widely accepted pretty much from the physicians, and there was a good turnout. Here I just documented the comparison of blood pressure and heart rate after Entresto and while the patient was on the therapy. So before, you can see that the blood pressure did go down and also the heart rate. I also looked at the hemoglobin and hematocrit after IV iron therapy. While there is minimal changes in the values, you can see there is a slight increase pre-intervention with post-intervention. So the number of patients who were not on guideline-directed medical therapy at discharge is due to a number of reasons. Either was AKI, hyperkalemia, or hypotension, and therefore they're unable to start either ACE, ARB, or beta blocker. Again, with the initiation of Entresto, we saw some improvements in blood pressure and heart rate. But again, these patients were hospitalized and they were monitored by the physician, so other factors play a role as well. Many heart failure patients do have anemia and low iron stores, and IV iron was well tolerated, and it could provide positive outcomes in these patients. But again, the study time was too short to conclude anything. And a lot of these patients, because diabetes is a comorbidity, they are candidates to start empagliflozin and hopefully improve cardiovascular benefits for these patients. And recommendations that were not accepted were either lost to follow-up, up to the physician's clinical judgment, or patients were discharged before the interventions could be made. So through this project, working with the TOC service that we have here, and also collaboration with the physicians, the pharmacy team here can work to help reduce heart failure readmission rates and improve outcomes in these patients. It's really exciting because pharmacy can really expand their roles as vital members of the multidisciplinary team here. And hopefully through this project, it will be implemented daily into the pharmacist workflow so that the clinical pharmacist can continue to make these interventions and we can see positive outcomes. And that's my presentation. Thank you.
Thank you very much for your presentation. I don't see any questions currently from the audience, but we thank you for all the work that you've done and continue to do in our residency program. Thank you.
Thank you, Michael.
So at this time, it's an honor to be able to introduce our keynote speaker today, KP Yelpaala, who is the founder and CEO of InOnHealth, formerly Access Mobile International. He's a friend of Adventist Health White Memorial. He's currently working with Dr. Nilan Patel, our co-chair for research and publications, to improve diabetes control in our community through innovative communications. He is an entrepreneur and public health practitioner with a deep understanding of health systems and 20 years of experience working across the public and private sectors in the United States, East and West Africa, and the Caribbean. He's an expert in national scale health program implementation, technology innovation, and the intersection of health equity and technology policy. Prior to founding InOnHealth in 2011, KP worked at the Dahlberg Global Development Advisors and served as one of the early employees of the Clinton Health Access Initiative. He was recently appointed by Governor Jared Polis to serve on the Colorado eHealth Commission. KP also serves on the Yale School of Public Health Leadership Council, American Hospital Association Rural Health Insights Leadership Forum, and the Expert Council of the Axios International. He also teaches graduate students at the University of Denver's Joseph Corbell School of International Studies. KP is a regular speaker in U.S. and international forums and has been featured in media outlets including CNN, CNBC, and NPR. KP also holds an MPH from Yale School of Public Health and a BA with honors from Brown University. And again, it's my honor to introduce KP as our keynote speaker today to discuss recalibrating the new normal.
Hello, everybody. Thanks so much for having me here today. Really looking forward to talking a bit about what we've been working on in our partnership with Adventist Health White Memorial, which has been great. So I'm just going to dig right in. My name's KP, as you know, and I'm the CEO and co-founder of InOnHealth, formerly known as Access Mobile USA. So I'll just talk a little bit first about what we do so you have some context. We're on a mission to improve access to health services and information through data-driven digital health communications for diverse populations. The history of the organization goes back to the African continent, where we've worked in over 13 countries using particularly mobile channels to support communication around healthcare needs. You can imagine in that type of context, you deal with diverse populations, lots of language, urban-rural divide. And we learned a lot about how to engage people across different cultural contexts that plays out in a very relevant way here in our country as well, in the US. So what do we do? So we work with health providers and plans to communicate with precision and cultural awareness to drive health outcomes for diverse populations. And what that means in our model is that it's not as simple as just sending messages to people, but it's really about using data to understand what people's needs are and how to segment your population. Content that's relevant to specific audiences. And so how do we think about communication in a way that people really connect to? We're going to talk about that in the COVID context shortly. And then behind that, we have HIPAA and TCPA compliant technology to automate those communications at scale in a way that's targeted based on our community needs. So as I mentioned, we have this technology that really is about using the most appropriate channels to reach people. And what we know is for a lot of populations, and particularly populations that White Memorial serves here in East LA, we may not find them on the patient portal, but they may be very active on their phone, for example. And text messaging becomes a really great way to connect with people regarding their care needs. And so we've been doing this work not just in the COVID space, which we'll talk about more today, but across lots of different areas of needs, ranging from population health to care compliance and other things. And this also involves, some of you may be wondering, it also involves interactive communication, so two-way texting and really having a dynamic engagement with stakeholders. So I'd love to talk now a bit about our partnership with Adventist Health White Memorial. Really the focus from the beginning, and we were formerly known as Access Mobile USA, was really around how to increase access to health services and how to support health literacy around critical needs for the community. And the first thing I want to say is I want to share a lot of gratitude to the White Memorial, Adventist Health White Memorial team, and specifically to Mara and colleagues who really were the first people in the US to see that we could take the model that we built in a global health context and really apply it to serve people here in East Los Angeles and other communities across the country. So Adventist Health White Memorial will always be our first partner and client in the US, and we are very, very grateful for that. The first work that we really started doing was around appropriate service utilization. Really look at the population, trying to access phone numbers, figuring out what phone numbers were valid, really trying to think about how in a compliant way to message people so that they can engage around their care needs. There's another area of work which has been around population health over time. I'm really talking about the pre-pandemic work that we had started doing. There are some channels we were working on with our program needs around program adoption. So really looking at different programs that White Memorial is trying to make available to the community and how we could communicate to people outside of using traditional channels to make people aware. We've done a lot of work with Dr. Patel and her team around diabetes care compliance. So the use cases are wide ranging. So the model I described can be deployed for different types of priorities that an organization may have, and in this context, Adventist Health White Memorial. Today, I'm going to speak specifically about what we've been doing on the COVID-19 when the pandemic hit, because we had a significant amount of engagement with the community around really matters of life and death, frankly, in terms of getting people the right information they need and doing other things. So I'm going to talk about our COVID-19 work. So our goal with Adventist Health White Memorial was really to support the organization, which was, doing tremendous work and really, really on the front lines and stretched to support its communities to reduce morbidity and mortality around COVID-19. And specifically think about high-risk populations and scenarios. So we had different types of populations we were already engaging, and then we needed to basically pivot our communication strategy. And so we're looking at the covered lives, we're looking at elderly population who are specifically at risk, and then also clinical segments that had significant risk with regards to COVID based on the evidence. Our messaging increased dramatically, as you could imagine, during the pandemic. From mid-March to mid-May, we were sending almost 12 messages per month regarding COVID needs of the population. And this tapered a bit, but continued over the course of the whole year. But there are some things that are really interesting. Usually you would think, in patient engagement, if you message people too often, they're going to opt out. Or if you message people with information that they don't find important, they're going to opt out. And when someone opts out, we lose an opportunity to engage. So it's one metric that we measure, right? Even though we increased the amount of communication significantly, our opt-out rates remained very low throughout the course of this, which showed us this was information that people were really needing and wanting. And importantly, it was coming from a trusted partner or a trusted community organization in Adventist Health White Memorial. So given that Adventist Health White Memorial was putting this information out as a trusted community partner, and it was critical information, we had significant engagement in the words of low opt-out, we had high click-through rates, and we even had several people replying to text, both in English and Spanish, sending us very positive and appreciative responses on what Adventist Health was doing to support them in this really difficult time. We sent almost 400,000 messages reaching over 20,000 patients related to COVID. If you look at the types of trends, so we found that if we looked at our Spanish first speakers by preference, they tended to engage significantly to our content and relatively more than our English first speakers, which we've seen over time in the population. And it's something that we're trying to unpack, but that segment does engage well. Opt-outs do taper over time and have remained really low with this type of content, as I had mentioned before. The things that people were engaging, the content that people were engaging the most were around what we call actionable links. In other words, this is information that was being shared through the texting channel that someone felt they could take action on was important. So information that we were sharing around like screening tools or how and where to book a vaccine appointment, things of that nature. And then also Adventist Health White Memorial is doing significant work in the community to get people access to food resources, to other community organizations that could support them in what was and has been a really challenging time. So that type of content, you could see people were engaging very proactively as we were sending messages, which lets us know that Adventist Health White Memorial is reaching out to them with things that they cared about that could ultimately get them the services and the tools and the things they needed to be in a better place through this pandemic. And as you see, as I mentioned, like information on food resources, issues around vaccines, but also like safety in errands. So how do you go about your life in COVID? What do you do? What should you not do? Where is risk? Right? Things of that nature that people were confused about. Like, do I just stay home? Can I go to the store? What do I need to do? That type of content had the best engagement, and we were very happy to be getting that information out to the community. Also, this was an area that was not a traditional use case for us, but that really became important during the pandemic. And this is about people under investigation. So the goal was really to monitor COVID-exposed staff for 14 days post-exposure. And in the prior model, this really involved lots and lots of phone calls. And the team was really stretched to try to drive this protocol. And so there were basically two key questions that needed to be asked around PUI and at shift change. And so what we were able to do is automate that by text message on a regular basis. And we were able to get over a 70% response rate on those text messages, people filling them out. So in other words, that meant that phone calls only needed to be made to the balance of the people, so less than 30%. And so this really supported the staff and the employee health unit in really trying to protect the staff, but doing it in a way that allowed the staff to be able to focus on other critical priorities during the pandemic. So we're really happy to use this use case to take some pressure off the Adventist Health Memorial team and the employee health group. Return to care. So you can imagine, as there are many people with different types of care needs who were not coming to the hospital. But as we started to get protocols in place, we needed those people engaging, right? And so whether it's behavioral health services around if people with chronic diseases such as hypertension, regular visits, we then use this communication channel to help people understand that they could return to care and what the process would be, and the Adventist Health White Memorial was creating a safe environment for them to deal with their other health challenges. And so we were doing this also in the diabetes space and using the channel to get information out to people if they were not coming to the clinic or for another reason couldn't. So we were able to kind of use these communication channels in different contexts to support the return to care and kind of care compliance context. And so if you just think about this in a framework across the spectrum, the COVID messaging over time moved through these different phases from the beginning of the pandemic, working with Adventist White Memorial to now. So it started with prevention. This is basically pre-vaccine, what to do if COVID positive, service changes, how to go about that. And then now moving more to return to care and vaccination. So you could see how the types of communications evolved over time to really support the community, not just with COVID, but also with others' general care needs. I want to transition and talk a little bit about what we're doing on health equity efforts for COVID and beyond. And it relates to the important work Adventist Health White Memorial does in its community here in East LA. Something that we realized, and we started doing this work in Colorado with the largest vaccine provider in the state, which before vaccines was doing testing, is they needed a way to determine how to target their efforts with regards to enhancing vaccine access through an equity lens. And so with limited resources, you can't go everywhere. So how do you prioritize where to go? And so what we did is we created this COVID Community Needs Index, which takes in a publicly available data along with data from the organization to help them prioritize. So in this case, we're looking at vaccination rate data that's publicly available at the lowest level geography that it's made. So in Colorado, for example, that data is available at the county level and it's updated regularly. In other parts of the country, you can get that data down to the zip code or census tract level. But that vaccination rate we're tracking over time. And then we're using an indicator that's called the COVID Community Vulnerability Index. This index is probably the most used index around COVID vulnerability right now in our country. It's built on the CDC's Social Vulnerability Index, and it really tells you down to the census tract level, relative burden or vulnerability if COVID was to become rampant in that place, right? So it's a way to help people plan from that lens. But it doesn't tell you how that changes over time and where to go. So once you add the equity dimensions such as age, race, ethnicity, even gender, you combine those into an index and you feed other data from the org into it, you end up with a scenario that's quite useful for planning. And so in terms of definitions, this kind of lays out how we think about definitions. But we take the vaccination rate, we take the CCVI, we take equity dimensions based on our partner's needs, and then it turns into a score. We used to call this a risk index, but we realized that wasn't the appropriate term because we're not really talking about risk. CCVI might actually be more doing that, but really talking about prioritization. So what you're seeing here now is every zip code in the state of Colorado rank ordered by how we measure risk based on the calculation. And what this tells our partner is if they want to have the biggest impact through the equity definition that they've defined, which uses race, ethnicity, which uses social and economic vulnerability as key drivers, along with population density and others, then that helps them plan. So here you'll see this zip code, 80219 in Colorado. Highest score, you'll see a significantly BIPOC population, significantly Latinx. Vax dose rates, you see what that looks like at a county level, but when we calibrate it down, this place looks like it's an area that needs focus. So our partner in Colorado, now this index being used in other parts of the country, is using this to actually decide where to knock on doors. So we've linked this information to publicly available census tract data. So you can scroll down and see what that looks like for the geography. But more importantly, it goes down to also a census tract level. And so when you use this index, it allows you to actually even figure out where to knock on doors. So our partner in Colorado took this data for Denver Metro and then rank ordered by our index, and then deployed teams door to door regarding vaccination access events that they were doing in that community. And so this is some of the work we're doing and how we're using data. We also can use this to track where the need is to communicate with people. You can imagine overlaying data around who to text where, what campaigns are running where you have pop-up sites or mass vax sites, and overlaying those data points along with the health equity measures. So when we look at health equity generally, we think about a few things. So it's really about removing data bias. It's about asking the right questions. It's about how we define our equity dimensions and what equity means to us, and then how we measure through that lens. And then ultimately it helps us prioritize our resources, and it helps us seek the right type of input from our different equity stakeholders that are helping us serve our communities. And then lastly, when we think about innovation, we think that innovation really comes in making this data accessible to organizations so that they can use it, and that it doesn't just sit in the hands of, let's say, state government or other planners. So when we think about communication. So I want to wrap this into now how we target our interventions. This information, and I'm just going to go back, this information you're seeing here, it also tells us where to communicate and where to engage, right? And so when we think about going into a context post-pandemic, we think that this also helps us think about how to prioritize our interventions. It helps us think about how and where and what type of information is needed, but also how to measure and align those communication efforts into those geographies. So this is something new that we started working on. I wanted to share. It's in our innovation pipeline. I mean, frankly, this is actually just rolled out in the last 10 weeks. And it started in Colorado. It's being used in Atlanta. We'd love to be using this here with Adventist Health White Memorial and in other parts of the country. But I did want to share this as a kind of new area of exploration and to prime our minds to think about the intersection of how we do text messaging and engagement and the things that I showed before, and how you can combine that with data through a health equity lens. So I hope that this has been informative. I really appreciate the opportunity to share with you some of the work that we're doing. And I think that as we think about engaging our communities and we think about health equity, we can start to think about how these types of tools of data analytics and insights can combine with our community programs and our communication efforts to really help us maximize our impact in our communities. And so with that, I'll leave it there. And I thank everybody for listening in. And I hope that you gained some new insights into not just the work we're doing with Adventist Health White Memorial, which we're very appreciative of, but also how we can think about health equity into a post-pandemic time. Thank you.
Hi, I'm Catherine Dufour. And sorry. This is my.
Hi, I'm Kim Ko.
Kim Ko. So we're going to be presenting from an article we wrote with Dr. Liu about GM1 ganglioside antibodies and COVID-related Guillain-Barre Syndrome, a case report, and then a systematic review of Guillain-Barre and COVID-19 infections, and then the implications for vaccine development. So first off, just as a background, I was just going to discuss Guillain-Barre syndrome. So in Guillain-Barre syndrome, what happens usually after some type of infection, usually a GI infection with Campylobacter, your body is actually, after it fights the infection, it makes an antibody that actually cross-reacts with antigens on our nerves. And because the antibody sticks to the myelin sheaths on the nerves, it causes the immune system to actually cause demyelination, which leads to ascending paralysis, muscle weakness, and also sensory issues. And so since COVID infection has started, it's been almost just over a year, we're finding that there's instances of Guillain-Barre syndrome and a Miller-Fisher variant, which is basically where it's descending paralysis instead of ascending. So, and the cases for GBS related to COVID-19 before this case study have not been positive for the most common glioside antibodies that we see in Guillain-Barre syndrome. So for our objective for our study is we did a literature search looking at Guillain-Barre and Miller-Fisher variant related to COVID-19 infection. And then we also are presenting the first patient with COVID-19 related GBS that demonstrated GM1 antibodies. So then I'll let Dr. Ko speak.
Okay, so I'm just going to talk about the case now. So we had a 36-year-old woman that was obese. She came to the ED with 3 days of progressive ascending weakness. On the day of admission, she was unable to stand or ambulate. Oh, disappeared. Sorry. Okay. And she had a positive nasal pharyngeal swab for COVID testing about 3 weeks prior to coming to the ED. At that time, she had experienced loss of smell and taste, generalized malaise, and mild shortness of breath. And she was released after 1 day of hospitalization, and she recuperated at home. She didn't receive remdesivir or steroids. So on neural exam, she was oriented and coherent. Her cranial nerves 1 through 12 were all intact. Her upper extremity strength was 5 out of 5, but her lower extremity strength was 3 out of 5. There were no sensory deficits, and she had absent deep tendon reflexes. And she didn't have any bowel or bladder issues at that time. So as you can see with the photo at the bottom, in like phase 1, you'll have like some tingling in your hands and feet. And then you'll have in phase 2, you have some difficulty arising from the chair. And then at phase 3, that's when you have areflexia or absent tendon reflexes, as well as weakness and distal sensory loss. So an MRI of her head and spine, they were negative for demyelination or any infarct. Her spinal fluid analysis didn't show any white blood cells, any red blood cells either, but it did show protein of about 20. The ganglioside antibody panel was positive for this patient for multiple antibodies, which we'll show in a table later on in this presentation. So she deferred any electrodiagnostic studies at the time. The patient's lower extremity strength continued to worsen during her hospital stay over the 3 days. And then eventually she got intravenous immunoglobulin at that dose that you see, 400 milligrams per kilogram per day. That was administered for 5 days. So after a week of being hospitalized, her strength began to improve. And so we actually followed up with, or Dr. Lu followed up with her with a phone call 3 weeks later and found that she's actually able to ambulate at this time with a walker, even if it's just for short distances, with a cane as well.
So just to talk on our methods and results. So on August 28th, 2020 is when I did the literature search for any articles, case reviews that were related to Guillain-Barre, Miller-Fisher variant, and COVID-19. In total, I found 102 articles, 8 were review papers. So then what I did is I looked at each case in each paper and made sure that the cases weren't duplicated. And we found that there was a total of 83 cases related to Guillain-Barre and Guillain-Barre and COVID-19. There were only 36 of the 83 patients had glioside antibody testing, and of the 36 patients tested, 31 of them were negative for any type of glioside antibody. So in those cases, we don't know what the target was that induced the Guillain-Barre syndrome. And then there was one case that was equivalent for GM1, which is one of the most common antibodies seen in Guillain-Barre. And so if you look at the table, this is the 4 other cases. So these are all the reported positive antibody testings. And then you see in our case at the end that she had GM1, GD1A, GD1B. So she had multiple positive antibodies, including the most common, which is GM1. So that's the first reported case of Guillain-Barre with COVID-19, showing a GM1 positive antibody. So our conclusion is that even though there's limited testing in patients with Guillain-Barre and COVID-19, we see that, and the antibody, even in those tested for antibodies, a lot of them tested negative for the common antibodies seen in Guillain-Barre, but because IgIV works, it helps support that the cause of Guillain-Barre and COVID-19 is a similar mechanism as traditional Guillain-Barre. And this just raises concern that the target for Guillain-Barre and COVID is unclear at this point. And some targets that may be causing the Guillain-Barre are angiotensin 2 or heat shock protein, which are also being used in developing the vaccines for COVID, which points to there's some risk of patients getting a COVID-19 vaccine developing Guillain-Barre, although the risks of getting COVID are a lot worse. So I would definitely still get vaccinated. But this is just an area of research that we can look into to find what targets are causing Guillain-Barre and COVID-19. And these could be possible targets for future vaccines, as well as help preventing COVID-related GBS in the future. Thank you. Here's our references, and just big thank you for Dr. Liu. Thank you for Dr. Ko for helping me with this presentation and with the paper. And then thank you, White Memorial and staff, for all the support and help.
Dr. DeFore, thank you so much, and Dr. Ko. Okay, so our next presenter will be Dr. Brian Kong for the Internal Medicine Department.
Good afternoon, everyone. My name is Dr. Brian Kong. As mentioned, I am a third-year resident with internal medicine here, and got quite an interesting case to go through that we took care of. You can see from this, it's a multifocal, multisystem Langerhans cells histiocytosis in adult female, but with an atypical presentation with recurrent abdominal pelvic abscesses. And so this was actually presented at Endocrine Society this year, just a short time ago. This is the poster I put up, but to make it more palatable, we'll have some PowerPoint slides, but we can come back to this later at the end. So some background on LCH. It's a rare histiocytic disorder. There's aberrant proliferation of myeloid, so kind of the progenitor cells that have produce all our other like myeloblasts and things like that. There's an abnormality with this. It has a couple of markers, as you can see, that are associated. It's quite rare. Children are the predominant ones, with 3 to 5 cases per million people or per children, and adults are essentially half. 1 to 2 per million. Now, these numbers vary given how rare it is. The true incidence is not quite so known. Possibly more in males, seems to be more prevalent in Caucasians. Now, the presentation is highly variable. As my title implied, this patient is multi-system. It can be single organ. And this can go from bone marrow, skin, lymph, liver, spleen, lung, CNS, multitudes. And within those organs can be unifocal to multifocal as well, with different foci within the same organ. And so ours is of the more complex form, an adult with multiple systems with multifocal aspects of those. But in addition, notably with some very associated abscesses, especially soft tissue abscesses. So to go into the cases specifically, she's a 38-year-old female, history of remote polysubstance abuse, type 2 diabetes, PCOS. Her initial complaint was quite vague, just nausea, vomiting, abdominal pain, right lower quadrant. Of note, she had been had prior hospitalizations in the past, multiply so, with these recurrent soft tissue abscesses. She noted to us a quote bone cancer, but she was not medically literate and couldn't give us too much information on that. And her initial presentation with us was more of a hypovolemia and sepsis. And she had a very extended course, but for the sake of time, I'll get to the tidbits. And she had a very severe hypernatremia when she was NPO for a variety of reasons, kind of unmasking a central diabetes insipidus. So imaging we obtained showed multiple things. Abdomen and pelvis, given the multiple aspects she had presented with initially. And it's kind of hard to see on the screen, but you can see actually, especially in the acetabulum, the ileum, there's multiple punched out kind of lesions, noting the osteolytic lesions. There's also significant fluid collections, which are the abscesses. A very, very large one on the right, 13 by 11 by 14, and in some left groin, it's kind of scattered throughout, along with some hepatosplenomegaly. With her sepsis, she grew up quite a few organisms. Blood culture was only Klebsiella for her bacteremia, but when IR had to go in to drain and also place a drain for continued drainage, it grew out multiple things: MRSA, Citrobacter, Klebsiella, E. faecalis, Candida. So while we were treating her with antibiotics and we kind of changed them towards the cultures and whatnot, and also repleting her because she was incredibly hypovolemic, we also had some things cooking. So given her presentation, given her imaging findings, the osteolytic lesions, the lymph, and these abscesses, we I had endocrinology on board because of the hypophysitis, the central BI. And it was actually Dr. Hyun who was the trigger to helping us identify possibility of LCH. So we obtained samples from outside the hospital, and actually was positive for S100, CD1A, and actually kind of confirmed the LCH for us. Because of this, we got oncology, Dr. Chen, and with consultation with City of Hope, underwent induction chemo, IV vinblastine, along with concurrent prednisone, also received bisphosphonates. Patient actually did quite well on this regimen. And of course, we continue antibiotics. She had profuse amounts of IV fluid because of significant dehydration. She did end up getting approximately 7 units of PRBCs. With the LCH, her production was low and was severely anemic, and also had a very difficult to control diabetes and had up titration of her insulin. Throughout her course, she was pretty much here for about 2 months and was discharged with close follow-up with good improvement though. And she was established oncology, endocrinology, and a PCP with our office to try to keep on top of her, to keep managing and monitoring for her. You can actually see some of the slides here. And we had great help from our pathologist who was able to show us some fantastic slides notifying that were indicative of these markers for the LCH. So in terms of discussion, why is this case particularly meaningful? Well, in and of itself, LCH is very rare. Now, the typical ones are in children and typically a single organ, unifocal, et cetera. This patient is pretty much the polar opposite. She's an adult, she's female with the predilection of the possibly for male. She's multifocal and multisystemic. And not only that, with a rare incidence of it, she has these recurrent large abdominal pelvic abscesses, and they have been strongly associated with her LCH. So our case report brings up such an unusual case, and given the rarity, we want to highlight the possibility of soft tissue being involved in LCH. LCH can be a very disseminated disease, affects many, many organs. It is not untoward that it would have soft tissue involvement as well, especially with how sick they can be. And so we had gone through prior literature and nothing had been noted, but when we do reviews of LCH, the predominance is case reports with a smattering of kind of a multi-institutional analyses, meta-analyses to try to conglomerate all of these. And even then, the sample sizes are quite low. So this is further evidence of more information towards that. We want to give acknowledgements to Dr. Lin Bui, our radiologist, who helped us with images and identifying particular ones, and also Dr. Chandrika Seneviratne, who was our pathologist and helped us with slides with those. Actually, we have more imaging and more slides And before I go back to that, here's just a list of our references. And let me just touch back to the poster. And actually there's, if people so desire, there's a code at the top right. You can scan it with your phone. It actually has more images, more of the HISTA slides for your perusal, kind of going into more in depth of the findings diagnostically that we had. Okay, so there's she's quite extensive case, but for the sake of time, just the high value, high yield nuggets for that. I'd like to open it up to any questions at this time.
So Dr. Kong, I don't see any questions.
Sounds good.
So I really want to appreciate you for the presenting this interesting case.
I appreciate it. And another shout out to Dr. Chen and Dr. Hyun, who were pivotal in the treatment for this. And Dr. Hyun definitely caught it, and Dr. Chen was pivotal in the treatment of this case.
It goes back to the importance of communication and follow-up in these difficult cases. So our next presenter through internal medicine is Dr. Kajani and Dr. Haratunian, examining the use of later jet procedure to repair a bony Bankart lesion after a hockey fight.
Hello, this is Dr. Kajani. I'm here with Dr. Haratunian. Thank you guys so much for your time. So we have our case presentation that we did with Dr. Itamura here at the Kerlan-Jobe Institute at White Memorial. So we have a case of a lateral J procedure to treat an anterior glenohumeral instability in an athlete with recurrent shoulder dislocations. So we're going to break this up into a typical case report type of format. And so we'll just jump right into it. So anterior shoulder dislocations are one of the most common injuries, especially in young athletic populations. Shoulder dislocations account for 50% of all major dislocations, and majority of those are going to be anterior shoulder dislocations. A lot of times, anterior shoulder dislocations are associated with injuries that can lead to glenohumeral instability, including the Hill-Sachs lesion and the Bankart lesion, which is what we're going to be diving into a little bit more deeply. So the Bankart lesion is the disruption of the glenohumeral labrum, specifically the inferior and anterior portions of that labrum. And it gets disrupted during anterior dislocations. 90% of patients under the age of 30 with anterior shoulder dislocations will have a Bankart lesion, as you can see in our images over here. Bony Bankart lesions, which involve an avulsion of the glenoid fossa with the disruption of the labrum, occur in 5% in that same population. So this is a pretty common occurrence. Typically, you can treat these non-operatively or with arthroscopic repair. However, with more bone involvement, there are higher rates of recurrent anterior glenohumeral instability. In those cases, the lateral J procedure has been shown to become the treatment of choice to prevent this anterior glenohumeral instability, especially with patients who have high bony Bankart lesions or in young athletic populations. And so we'll just jump into the case with Dr. Haratunian.
Hi, everyone. So we are presenting a 22-year-old male, a hockey player professionally, who presented to the clinic for an anterior shoulder dislocation that was as a result of an in-game fight. The patient had a history of anterior shoulder dislocation with Bankart lesion, which was already repaired arthroscopically in 2003. However, he had a recurrent shoulder dislocation, and immediately after that, the team physician relocated the shoulder and placed it in a sling and referred it to the clinic. Upon presenting to the clinic, patient did not have any dead arm symptoms, which basically means there are no neurological symptoms such as numbness or tingling or any other neurological deficits. On the physical examination, patient was in no acute distress, regular heart rate and rhythm. Patient did not have any crackles or wheezing, which was reassuring that none of the part of the fracture was actually damaging to the lung. For the MSK exam, we had a left shoulder, which was displaced in apprehension with forward elevation and external rotation of his left arm, which is typical presentation in anterior shoulder dislocation. And there was pain associated with external rotation and supraspinatus strength. And also patient had a positive belly press and bear test, which are significant for subscapularis muscle deformities. Range of motion was limited due to pain. Again, patient did not have any neurosensory or neurological deficit on the physical exam, and there was no skin lesions or lacerations on the physical exam. Going to the imaging on the very left side of the pictures, you can see there is an MRI, which where we pointed out, that's the part of the glenohumeral rim and part of the glenoid, which is not very clear over there, but you can see the disruption of the compartment of the glenoid labrum rim and part of the basically bony part of it. On the middle picture, which is the X-ray, if you guys can appreciate, there is a fine hair-like bony fracture, which I tried to put a circle around it so you guys can appreciate that. And with this imaging and the physical examination, there was a time to make a decision what kind of a treatment the patient will benefit at this point. So the decision was made to proceed with the J procedure, given the significant osseous involvement of the labrum rim tear, which was almost greater than 20-25%. And also the fact that the patient had a history of shoulder dislocation, which was already repaired with arthroscopically almost 7 years ago. So this is an intraoperatively image, which thanks to Dr. Itamura, who shared this with us, so you guys can appreciate, which Dr. Kajani will explain the process of it. And on the right side, you can see the post-op X-ray, which shows basically the screw that it's being basically placed in part of the glenoid. So going to the recovery time, following the surgery, patient was able to regain most of his range of motion in a very short period of time. There was no complication in post-procedure, and the patient is currently going under physical therapy, and the return to play time is usually 3 to 6 months, but it also depends how fast the athlete is basically responding to the procedure and to the physical therapy.
So we'll just jump into what is the lateral J procedure and why is it so effective. We kind of talked about how it does treat glenohumeral instability, especially in these young athletic populations and with people with significant bone involvement. The procedure is an open procedure that involves the transfer of the coracoid process, which you can kind of see in our graphics on the right side over here. The coracoid process is detached from the rest of the shoulder joint, along with its associated structures, including the anterior, the coracoacromial ligament, as well as the conjoint tendon of the coracobrachialis and the short head of the biceps. Those associated structures remain attached to the distal coracoid, and the distal coracoid is removed and placed into the glenohumeral fossa, particularly in the areas where there is the bony deficiency. Those three associated anatomical structures do then provide 3 different mechanisms to provide support for the shoulder. And this creates a triple block effect. So the coracoid process itself is shaved down into a bone graft, and that is then placed onto the glenoid fossa, which acts as a mechanical block. Then the remainder of the coracoacromial ligaments are used to augment the capsular repair of the shoulder joint capsule, providing a soft tissue block. And then finally, the conjoint tendon itself will be attached to the coracoid process still and will provide support to the inferior 1/3 of the subscapularis muscle. And this is called the sling effect, which is the primary stabilizing mechanism in the lateral J procedure. As you can see with this triple blocking effect, the lateral J procedure is extremely effective in preventing recurrent anterior instability and has been shown to prevent this in 94 to 99% of cases in some studies. Moving forward, Dr. Hartunian has some differences between the 2 procedures.
So they did a meta-analysis and they compared the lateral J procedure with the traditional arthroscopic Bankart Lesion, which there was a total of 8 studies, and they compared with each other, and they found that in the lateral J procedure, the recurrence rate of anterior shoulder instability was shown to be far lower than the typical Bankart arthroscopic repair, which it was 11.6% compared to 21%. So we can see it's almost half, 50% lower rate of shoulder instability in recurrence. And also another thing that they found was there was a less of loss of external range of motion with Lateral J procedure compared to arthroscopic repair. So people who had the Lateral J procedure, they only had 11.5 degree of external rotation loss, compared to people who did the traditional Bankart repair, they had almost 21 degree loss of their external rotation, which we can only imagine how devastating that can be for some professional athletes or anyone else. However, for the return to activity time, it was similar in both Lateral J procedure and arthroscopic repair, which was between 3 to 6 months. So with this, I think this was an interesting case that it shows the effectiveness of a new technique that we are using, the Lateral J procedure, over the traditional form of it. And with that, we would like to basically thank Dr. Itamura, who basically gave us the opportunity to present this case. And with that, we can take any questions that you guys have.
I don't see any questions in the chat except for one comment from your program director, Dr. Juan Barrio. It says, thank you, residents, for your excellent presentations.
Thank you, Dr. Barrio. Appreciate it. And thank you all for listening. Appreciate it, all your time.
Thank you.
And on behalf of Integrated Research and the hospital, we appreciate the work that you do too.
Oh, looks like we have one question. Is there a loss of range of motion? Dr. Hartunian, you can take that one.
Yeah, so as of now, because this was fairly new, like I could say maybe in the last couple of weeks, I think it was done at the end of the March. Right now, the patient didn't get full return of a range of motion. We can't say right now how much he had the loss of the range of motion. That's a great question. Right now, patient is currently going under physical therapy, and we kind of interview the patient intermittently, and we ask him to come back for reassessment. I think he has an appointment in the next week or so, but Evelyn, thanks for asking that. I will definitely keep you posted.
And typically there are regaining of range of motion with physical therapy. Of course, you won't have full range of motion with somebody who hasn't had a shoulder injury or shoulder dislocation. But the goal is to have as minimal loss as you can. But with any procedure, even the traditional arthroscopic repairs, you will never get full range of motion back, but instead try to sacrifice some of that for more shoulder stability. It looks like we have another question. Are there different types of interventions for traumatic versus atraumatic tears? So typically, our presentation did kind of touch on this, but essentially, if there is more than 20 to 30% of glenoid fossa involvement, bone avulsion with the Bankart lesion, then the Lateral J procedure is the indicated procedure to treat the Bankart repair. But additionally, it depends if on the clinical context as well. You know, for somebody who may have had a fall, and a 50-year-old who may have had a fall and dislocated their shoulder, they might not be inclined to even have the arthroscopic repair, let alone an open procedure. And so, clinical context does play a role in the decision of what treatment to pursue.
Yeah. Also, I would like to add that for people who had shoulder traumas involves in tendon tear or distal muscle disruption, which are atraumatic, there was a lot of studies that it shows only 15 to 20% of them, they actually require any intervention. And most of it, it's more like symptomatic physical therapy and regain the rest of the muscle strength with the group of the muscle strength, which can basically help, because all we know, no intervention comes risk-free. And there's some downsides to each one, which Dr. Kajani mentioned. It totally depends to the situation and the type of the disruption of the muscles that we're talking about. I hope that answered the question.
All right. Well, thank you guys very much for your presentation.
All right. Thank you all as well. Have a good day.
Thank you. So the next residency program to present is our White Memorial Family Medicine, whose program directors are Dr. Hiramura and Dr. Tarin. And our next presenter is Dr. David Lyons on identifying barriers to mental health service in East LA patient population. Can telehealth bridge the disparity?
Good afternoon, everyone. I'm Dr. David Lyons. I'll go ahead and share my screen now. Again, like our esteemed host has said, my presentation is the identifying barriers to mental health in our population here, and if telehealth can actually bridge that disparity. Dr. Moradak Mias was kind enough to be my advisor for this and help me go through this project. This is a quote that I tend to live by, that was given to us by a former slave who ended up becoming a presidential advisor. And it really speaks to especially our population that I'm also going to be addressing in terms of some of the barriers that they still have to face. So a little bit of background, as this is a project that I did on mental health issues. Mood disorders are actually a public health issue affecting millions. I mean, the prevalence for the last 12 months in one study showed that there was a 6.7% prevalence rate and a 16.6% lifetime prevalence of depression in one particular study. And of course, this will lead to a poor quality of life. There's several studies that have shown, various parts of life and how it affects, but there was one that found 4,500 people followed over 10 years. Those who had depression before or even after the study had started were found to be significantly less employed, and they were able to actually associate it with about 1.7 to 3.2 million adults being unemployed due to mood disorders. Then this goes into our the health issues, especially if they're comorbid with depression. So for those who have chronic back pain, it's just significantly limits the ability to even control the pain. And of course, those who are also suffering from mood disorders will typically be, for those who are diabetics, will be on more insulin, will typically be heavier in terms of their weight, as well as just have like higher rates of smoking and other unhealthy lifestyle behaviors, despite being similar age and education in some studies. And in one study in 1999, 31,000 people were actually found, were studied, and of those who had both diabetes and depression, they were found to have a significantly decreased quality of life and functional ability, such as just walking up 10 stairs, lifting 10 pounds, visiting friends. Now, in the past 10 years, mental health access has actually improved significantly since the ACA, as the essential health benefit, or EHB, is actually something that was created to make sure that mental health and substance use disorder services were included in all insurances. Now, despite this, there is still a significant barrier. Now, you don't need a doctor's referral to get mental health care. You can they got rid of that requirement and added, the phone number to your insurance to just request services. So that way, people who didn't have a primary care doctor or didn't see one were actually able to. But despite that, you still have issues with travel. You have other functional barriers to mental health, such as like co-pays, or even just knowing about the issue. And our population here in East LA is particularly at risk, especially now that COVID has made its mark, and we were all particularly affected and saw the effects here in LA. So they are significantly at risk for something called complicated grief, which is just the abnormal form of grief, where it tends to be prolonged, it tends to be more intense, it tends to be more disabling. They have dysfunctional thoughts and behaviors that's maladaptive to the loss that they experience, especially in the traumatic ways that a lot of our patients have experienced. And this leads to actually new diagnoses of mood disorders, PTSD, depression, anxiety. And this is not just unique to our population. This is actually unique to most minority populations in low socioeconomic status. This is a study that showed that despite 34% of an entire population of records that they looked into, which were in the millions, that and 34% were of Caucasian non-Hispanic race, the majority of the hospitalizations and death rates actually came from those of the minority populations. So telehealth was something that was actually brought up prior to the pandemics, and so therefore, since the pandemic, telehealth kind of became a huge thing. But prior to the pandemic, this was thought to help improve access by getting rid of the need to commute, travel, geographic restrictions to, say, therapists who weren't located in the nearby area, especially when there's such a shortage of those who actually see our patients, those who are underinsured. And a lot of the studies that have been done show that that telehealth for therapy and mental health services is actually considered non-inferior, or there's non-inferior results from telehealth therapy. That being said, you know, there's still kind of like some issues that could be, you know, a problem. You know, there could be other barriers. You know, do these patients have access to a stable internet connection? Do they have a smart device? Do they have privacy available to them in their own homes? And then, of course, if these studies that were performed to show that they were, you know, inferior, do they represent our population, populations who are impoverished or of low socioeconomic status or of minority populations? My methods was I looked at two different kinds of therapy referrals that we were doing in the clinic. So traditional therapy is what I essentially use to term the therapy that they can get from their insurance. This is an example of an insurance card, and most insurances in the back will have that phone number for mental health and behavioral health resources. Typically, and this is a very common practice among most primary care clinics, where a patient would need to initiate the call, whether it's by our instruction or for themselves, to actually be connected to mental health services. That way, it's sort of like, you know, is within their control, and they don't have to wait on others, like a referral, a doctor's referral, to actually get therapy. For the telehealth, we were starting to utilize USC's telehealth clinic, which is actually the flyer here. So they actually were providing free services for any LA County resident. And this was for mild to moderate mood disorders. We were we were telling our patients about it in the clinic when we initially instructed them to seek help. And we would typically provide them the flyer, and they are usually able to get 8 to 12 sessions, although these can be either extended or recurrent as needed based on kind of like what their needs are during therapy. So I looked at suites 402 and 230 for FCS, family care specialists, and all referrals that were made between September and October 2019 to 2020. The initial survey, well, not initial, but the survey was sent to 121 referrals or individuals who were referred to traditional therapy, and 95 individuals who were referred to telehealth. Now, unfortunately, the text message that was sent to them, it was via our UpDocs communications portal. I only ended up getting a very small number of patients actually respond. So I ended up making phone calls to individual patients to get some more data, which tended to take about 10 to 15 minutes per call. And many of them still had severe symptoms and actually needed a follow-up. And so that's kind of a little foreshadowing into it. This is what the survey looked like on the computer. It was usually varied between like 6 to 10 questions, and one of those questions were typically on their symptoms, whether it was the G87 or the PHQ-9. Now, the way the survey was is that there was actually many different questions that could come up based on how they answered the question. And that was so that way I can get a more variable or different answers or responses in terms of what kept them from getting therapy or how their therapy was. Another thing that I ended up looking at as one of the outcomes measurements was kind of their cumulative score of the PHQ-9 and G87 during these surveys. So based on that, so I was able to get a total of 53 responses after getting all the phone calls. Now, unfortunately, I did do several statistical analyses, chi-square and t-tests for the results, but unfortunately, likely due to the number, it did not reach statistical significance. So there was no differences that was actually observed in terms of whether or not someone who was referred to traditional therapy versus telehealth, whether one was more superior than the other in terms of actually gaining access to services. I used the measure of actually attending their appointment as the determination of whether or not they got services. So this is the T-score, T-test for the cumulative mood scores, which varied between 0 to 36. Now on the left, many people actually answered 0 to a lot of, or all of the questions on the PHQ-9 or G87, which sometimes was, relatively inappropriate, whether it's because they didn't want to answer. On phone calls, there were cases where they didn't want to answer or they didn't have time to answer. So you can see that, like, when I did the t-test, that the p-value on the left, which was with the 0 scores, was 0.71, while the one on the right was without, and it decreased to 0.64. Still insignificant, but because there was a lower p-score, I felt like it was more appropriate to focus on the ones without the zeros, of which case there were many. Here we have a graph of essentially both traditional and telehealth therapy patients who had G80, and essentially where their makeup of their score. So 1 to 5 being alone, 31 to 35. You can actually tell that people who had telehealth therapy tended to actually have more severe mood scores. Additionally, many of them, actually didn't get care. Of those who were surveyed, approximately 5 actually stated they didn't even, 5 out of 12 people who did not get scheduled actually didn't agree with the survey, with the referral, and 5 out of 30 of those who did not get treated or get seen didn't agree with the referral. While others, they actually did agree with it, but unfortunately they weren't able to initiate the referral, whether it was because they forgot. Others said, many of them actually said they didn't know that they had to initiate the referrals. And that may be true in the sense of they may not have been told, or it was forgotten during the appointment, or maybe they don't remember hearing it. But you can see that several of their responses for free text, when asked specifically what happened, as some of them did call, some said that when they called, they didn't get a call back or didn't get an authorization. So you can see that those who had traditional therapy did get more appointments, while those who had telehealth therapy had less. But those who were referred and didn't get to see anybody, they still wanted to see. 14 people from telehealth wanted to still see a therapist if the process was made easier for them. Limitations, obviously, small sample, convenience sample, no controls, plus traditional therapy essentially became telehealth after the pandemic. Now, conclusions real quick can just be the majority of the patients aren't being connected with mental health services, regardless of whether they're going to traditional or telehealth therapy. It shows a lot of them are easily discouraged, waiting for authorizations. I'm going to call, I forgot, wanted to get an eval, but I couldn't get an appointment. And we're essentially expecting people with mood disorders at the worst of their mood disorders, where they're not treated, to actually navigate the referral system, which is something that might need to be addressed in order to make sure that our patients are being connected to services. And another conclusion that can definitely be made, of course, is that people are still waiting to get connected to health services, even if they're not willing or able to connect themselves. These are my citations. I apologize for the extended presentation. Any questions?
Dr. Lyons, thank you for your presentation. I think there's one comment here. It was very informative and helpful. Thank you for a great presentation. And I agree, it's such a huge need in our community to address mental health, and just because it's available doesn't mean they can still get it. And then I don't think we can fully understand the cultural implications of seeking treatment for mental health in our community and what those challenges are. So I think there's a tremendous opportunity that we've already initiated on White Memorial's behalf to better serve our community. So thank you for this presentation. And next up, we have Dr. Tamby that's going to be talking about assessing and improving social determinants of health within the Boyle Heights, East Los Angeles community.
Yes, hi, good morning. Okay,
Dr. Tamby.
So my project was similar to Dr. Lyons in that I was trying to identify different social determinants of health within our Boyle Heights community. So assessing and improving social determinants of health within the Boyle Heights and East Los Angeles community. Okay. So, and I have a little quote here. It's not that the healthcare side hasn't known for a long time that social determinants influence what they see, but health systems are just not structured to respond to them. Okay. Okay, so our population here at Adventist Health, White Memorial, and the surrounding communities, we serve a population very much defined by the words underrepresented, underserved, underinsured, etc. The clinics and doctors' offices in the surrounding communities have adapted and developed ways to provide clinically for this patient population, but still today, practitioners continue to encounter patients who are experiencing difficulties with things like, paying their copay, buying medications, paying for food, utilities, paying their rent, etc. Likewise, we know that Los Angeles has one of the highest rates of homelessness in the country. And of course, we're not naive to the fact that as clinicians that we do have a percentage of our White Memorial patients that we see, especially on the inpatient side, who are experiencing homelessness. So what are social determinants of health? They are the conditions and the environments where people are born, where they live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life risks and outcomes. Social determinants of health are shaped by the distribution of money, power, and resources throughout local communities, nations, and the world. And differences in these conditions lead to health inequities or the unfair and avoidable differences in health status seen within countries and then between countries. So the US Department of Health and Human Services has the Healthy People, they had Healthy People 2020, now we're in Healthy People 2030, where social determinants of health are among its leading health indicators. And one of the goals, the 5 overarching goals for Healthy People 2030 is specifically related to social determinants of health, in which they want to create social, physical, and economic environments that promote attaining the full potential of health and well-being for all. And so for what we did is that we used a social needs screening tool to identify specific social needs of our outpatient clinic patients. These needs undoubtedly affect one's overall health and well-being. And with this screener, we aim to identify opportunities in which we could improve care for our patients. There's a growing list of resources constantly being added to. And so now what we needed to do is just identify which resources patients need and then find ways to improve their access to these resources. And so what we did ultimately is that we provided a survey via SurveyMonkey to a subset of patients. And so the survey was essentially a combination of the Health Lead Screening Tool plus the AAFP, American Academy of Family Physicians, social needs screening tool. And that was sent via either a text or email link to patients. So these two surveys, a combination of these two surveys, Health Leads, they have a screening toolkit, and it's a licensed toolkit, and it's available in both English and Spanish. And the survey screens for 5 core health-related social needs. That's housing, food, personal safety, transportation, and utilities. And then the Everyone Project by AAFP is an initiative to help physicians confront health disparities and improve the health of all people. And their latest toolkit includes a questionnaire that's meant to identify additional needs. And those are related to employment, education, health, childcare, and financial strength. The AAFP sent out a survey to physicians in 2017, sort of trying to assess what are the barriers for us as physicians in, identifying and handling social needs. And 83 of family physicians agree that we should be identifying and helping address patients' social determinants of health. 78% agree that we should partner with community organizations to address community health disparities. 75% agree that we should be advocating for public policies that address these social determinants of health. However, 80% of physicians feel that we don't have the time to discuss these needs. 64% of physicians feel like we're not staffed, properly staffed to address these needs. And 56% feel that we are just unable to provide solutions to these patients. And that's sort of how the Everyone Project came about and sort of what their goals have been. So this is the screening tool. This is the Health Lead screening tool. Here we see it in both English and Spanish. And you can see that this is just a 10-question questionnaire. And then this was the AAFP social needs screening tool. And this one was 15 questions. And so our methods were that initially we wanted to administer this questionnaire in person. However, we were unable to just given the pandemic. And so what we did is that we resolved to administering it online via our UpDocs telecommunication system that Dr. Lyons referenced. And so a secure message was sent with the link to the survey to 178 patients between October and March. And we tallied all the positive responses. And for the most commonly mentioned social needs, what we were trying to do was see whether or not we could have easily accessible resources in our EHR that providers could provide to the patients. And so, like I said, we had a total of 43 responses, and I'll just kind of go through this a little bit quickly, but what we wanted to do, I sent the survey out in both English and Spanish. And so I tallied both the English and the Spanish results very quickly. I wanted to know what insurances the majority of our patients had. As you can see, the majority did have either Medicaid, the state insurance, or private insurance. As far as worrying about, losing housing, I think the thing that struck me the most was that, some of these answers weren't zero, right? And so here we can see that we have a number of people who are maybe who didn't want to respond, sort of speaking to the fact that maybe there is still discomfort about addressing social needs with, others or with their provider. And so there is a concern for some patients in, losing their housing. Here, the question was whether or not you're worried within the next 2 months you may not have stable housing. And it was surprising to see that this wasn't, that how almost balanced this result was. Here we talk about, running out of money to pay for food and, being able to buy more. And this was, again, a concern for a number of patients. Running out of food. So in the past 12 months, has there been a situation in which you bought food that didn't last to the end of the month and you were unable to buy more? And there were some patients that entered, often this does happen. And then sometimes for other patients with, maybe just about 60% of patients saying that they did have sufficient. And so that's quite a number of people. Having enough money to pay bills. There are, again, a number of patients who said, yes, always, I'm unable to pay my bills. And then often, sometimes rarely. So actually here we can see that a minority of patients, less than 50% of patients, have enough money at all times to pay their bills. As far as, issues, with insufficient housing or where they live, insect infestation or having, lead pipes or paint, water leaks, mold, inadequate heat, these things did come up, a number of times for patients. And then just interpersonal relationship issues such as, being insulted or talked down to, as well as being screamed or cursed at. We see that there are patients who are frequently experiencing this, some that responded sometimes, some that responded rarely, but it is happening. And so we need to not turn a blind eye to that. And then a lot of our patients are actually experiencing unemployment right now. And so I thought that was very striking how many patients we do have experiencing unemployment. And so, you know, I just wrote here our results, which were that, you know, the majority of, not the majority, but there were a prevalent number of patients experiencing fear of, you know, food not lasting the whole month, not having enough money to pay monthly bills, inadequate housing conditions such as infestations or water leaks, you know, unemployment status, and then the lack of safety in the home. And so, you know, with our clinic at, you know, the FCS clinic in Suite 230, we have a total of 9,000 patients. And so I surveyed only 178 with, you know, a number of these, you know, responses being positive. You know, extrapolating from these results, we could, you know, essentially, you know, conclude that we may have hundreds, if not thousands, of patients who are dealing with some social need, a lot of which we already have resources for. And so there is a need for the healthcare providers to play a more active role in treating different aspects of health for our patients. Another role of the survey is to get patients more comfortable with bringing up, you know, personal, social, you know, social need issues with their providers, and then thereby normalizing these discussions. This is just a screenshot of our EMR and what, you know, we as a clinic have been trying to do. Dr. Castro, our clinic director, did, you know, in the very recent past, try to include this, you know, section for social determinants of health, in which, you know, we have listed all the social determinants. And then, you know, some of these are now, we're trying to sort of fill in for some of these needs, the different resources that we as providers can sort of provide. And so here you can see that for, you know, food insecurities or the, you know, lack of access to nutritious foods, we do have it to where, you know, we have the different resources now available in our EMR. And so we're hoping to have those filled in for every single one of these social needs, and, you know, make it easy for our providers to be able to, you know, hand these resources over to the patients. And so here I did just listed a couple of future goals, which is to, again, build more trusting relationships between patients and providers. And then once we can get this surveying implemented in the clinic setting, any patient who screens positive for social determinants of health with the questionnaire can be provided with a list of resources. And then how to access these resources will ideally be explained by the provider prior to departure. And this is a great opportunity to identify where we as providers can bridge that gap for our patients. And then lastly, for future projects, you know, contacting maybe as a future project, maybe contacting patients who were provided resources in clinic via telemedicine visit, and then following up with them to see whether or not they were able to access the resource, and then if not, why not? And that's it. Do we have any questions?
Dr. Tammy, thank you so much for your presentation. It just goes along with everything that's good that's going on in family medicine to address the needs of our community that are outside of the physical medicine. That social medicine is important also. And to wrap it up is Dr. Ashley Chavez. She's going to be presenting on improving food insecurity knowledge and confidence among family medicine residents.
So hi everyone, my name's Ashley, and I actually did my project with my attending Dr. Maria Cynthia Lopez, and we decided to do some research on food insecurity, specifically improving food insecurity knowledge and confidence among family medicine residents at our program. And a little bit of background is about the prevalence of food insecurity in our communities. So an estimated 13.7 million US households were food insecure at least sometime during the year in 2019. And this data comes from the US Department of Agriculture, and they get their data from the yearly census that they provide. And in California, actually, it's 1 in 4 households have had food insecurity sometime during the year in 2019. So again, food insecurity is defined as households with limited or uncertain access to adequate food to meet the needs of all household members because of inadequate finances or other resources. It is a major public health problem as it can lead to a variety of experiences and behaviors such as feeling stress and anxiety that food budgets may be insufficient, altering or reducing food intake to reduce food expenses, or even skipping meals. And these behaviors can lead to many poor health outcomes throughout an individual's lifespan, specifically higher rates of obesity, hypertension, and diabetes, which can in turn have their own complications. However, this problem is seldom addressed during healthcare visits due to lack of awareness and training of our physicians. Many of our physicians aren't trained to ask the sensitive question on whether or not their patients actually have enough food to eat. And when they come across this issue, a lot of them don't know where to refer their patients for food resources. And due to the lack of awareness, lack of information, they aren't able to tailor their management plans accordingly to best fit the patient's needs. So the purpose of our research project was to increase resident physician knowledge and confidence in screening for food insecurity and referring to appropriate resources, as well as increase patient access to those resources. So what we actually did was we administered a pre-survey consisting of 10 questions asking about knowledge and confidence on defining food insecurity, screening for this, and referring when needed. This pre-survey was administered to all of our 22 family medicine residents here at Adventist Health White Memorial Family Medicine Residency. A lecture was then developed to provide education on food insecurity and its impact on health, as well as the screening process and the resources available in our community to help better address the food insecurity problem among our patients. After delivering the lecture, the post-survey was administered to the same residents, consisting of the same 10 questions that were included in the pre-survey. And we used this data to evaluate for improvement in both knowledge and confidence. The pre and post-survey questions, the answers, the mean was calculated for each one of the questions, and these were compared using t-tests. In addition to this, we implemented a 2-question food insecurity screening questionnaire into our resident clinic electronic medical record system. And this was to be used by our residents to screen our patients during their patient encounters. And this has been tracked over the last 3 months. Lastly, flyers were created containing the resources in our communities. So there was a flyer made for food pantries, and this included the addresses and phone numbers to the food pantries nearest our clinic. There was also some information on the offices nearest to us that would help our patients apply for CalFresh, and the applications were available to our patients as well. We also included a flyer on WIC, who qualified for it, and the closest office to us. And lastly, a flyer with information on the Meals and Wheels program and how to get access to this and who qualified for this as well. These flyers are made easily accessible in our clinic to our residents and were provided to any patients who screened positive. This is the screening tool that we implemented into our clinic EMR. The first question you can see here, very simple. Within the last 12 months, we worried whether our food would run out before we got money to buy more. Often true, sometimes true, or never true. And 2, within the past 12 months, the food we bought just didn't last and we didn't have money to get more. Often true, sometimes true, or never true. This screening tool has actually been validated in both English and Spanish by the U.S. Department of Agriculture. And any positive response to either question is found to be 97% sensitive and 83% specific for food insecurity. This is some of our results that we got from our pre-survey and post-survey questionnaires. So you could see some of the questions here addressing the knowledge aspect. So I am knowledgeable about food insecurity and its negative impacts on health. I am knowledgeable about how to assess patients for food insecurity, and I am knowledgeable about what resources are available to address food insecurity in the referral process. So in calculating the mean for the pre-survey and post-survey, we did notice that there was a significant increase in knowledge as well as confidence when we look at some of the questions that were addressing that aspect. So I'm confident in my ability to discuss food insecurity, and I'm confident in my ability to refer food insecure patients. Lastly, we also were tracking who was being screened, and just during the last 3 months, so we had 57 patients actually screened by our residents in our clinic. And in conclusion, from the data, we gathered that most residents felt it was important to assess for food insecurity and refer when needed at baseline. However, very few had assessed patients for food insecurity or referred to appropriate resources. We did find that in educational lecture on food insecurity and the resources available, the screening process did lead to improvements in knowledge and confidence felt by our residents. And we did have some limitations that we wanted to mention. So it is a small sample size. It only included the 22 residents at our program, and it was a short follow-up time as we assessed them right after the lecture. However, there is a continuation to our study, and they will be further reassessed at a later point in time. There's also an inherent bias because this was self-reported data from the answers in the questions. And lastly, just for future ways to get past this are actually continuing to follow the rate of screening and the success of referrals. These are just some of our references, and that is all I have. Thank you.
Thank you, Dr. Chavez. From Dr. Kuborden, bias against obese patients for fat shaming can be prevalent among providers, especially in assuming that obese patients are not food insecure. What are your thoughts about providing training in this area?
I think as far as the bias goes, in terms of fat shaming, I think that it can be addressed. There are different modules in how to exactly, screen patients for these things and how to address the access to food and that problem, and specifically in how to ask the questions, trying to prevent any prejudgment felt by the patient. So I think that these can be incorporated into our food insecurity lectures for our residents to better address the fat shaming problem that Dr. was mentioning.
Thank you very much for your response and your presentation. And thank you for your work. So our next presentation is from Adventist Health White Memorial's Nursing and Allied Health. Diana Escobar will be presenting collateral damage impact of COVID-19 on stroke care in 3 downtown Los Angeles community hospitals. And she is currently our nurse practitioner managing our stroke program. Diana.
Hello, everybody. Good afternoon. My name is Diana. I'm here to present on collateral damage impact of COVID-19 on stroke care in 3 downtown Los Angeles community hospitals. And this was a collaborative work written with Dr. Liu, Michael Jordan, Kirby Rogers, and Dr. Ian Christensen. In addition to that, I will be sharing some more data on how COVID-19 impacted stroke care here at Adventist Health White Memorial. So during COVID-19, there was a decline in presentation of stroke patients in the acute care setting during COVID-19 lockdowns. This is partly attributed to patient misconceptions and fears about the virus exposure. Our write-up is a response to a similar work published by Sharma et al. In July of 2020, which demonstrated a 31.4 decrease in their stroke case presentation and a 46.1 decrease in stroke alert activation between March 23rd and April 19th of 2020. We focused on a comparison of data observations between March and May of 2020 compared to the same time frame in 2019 in 3 Los Angeles hospitals that are certified stroke centers. During this 3-month period, there was a 25% decrease in CBA and TIA case presentation with 222 cases in 2020 versus 296 in 2019. There was also a 43% decline in stroke alert activation with 208 in 2020 versus 362 in 2019. COVID-19 lockdown and winter surge potentially impacted stroke alert activation, admission, and hospital stroke care in 2020. Patients frequently came into the ER past the last known well of 6 hours, which was the Adventist Health White Memorial stroke alert activation window in Q1 and Q2 of 2020. We expanded this window to include a 24-hour last known well in June of 2020. As you can see, there was a drastic decline in stroke alert activation during the initial part of the lockdown, with the months most impacted being March and April of 2020. In regards to our stroke alert and stroke data for specifically Adventist Health White Memorial, there was a severe drop in stroke alert activation in 2020, which is evident compared to 2019 and 2021 data. As you can see, this was also impacted at the end of the year during the COVID-19 surge. The lowest drop in stroke alert activation was during March and April of 2020, with only 7 and 4 activations subsequently per those months, as well as a drop in daily ER visits and hospital admissions. There was a total drop of 18.1% in stroke case numbers in 2020 compared to 2019, with 295 cases in 2020 versus 361 in 2019. In terms of the COVID-19 surge impact on stroke care, there was impacted here at our hospital from October 2020 to February 2021. During this time, there was a 26.9% drop in stroke cases in Q4 of 2020 versus 2019, with 68 cases versus the 93 in 2019. There was also a 13.3 drop in stroke alert activation in Q4 of 2020 versus 2019, with 72 versus 83 activations. This is despite the increase of a last known well window from 6 hours to 24 hours. Patients were frequently coming into the ER with symptoms past the last known well for a stroke alert activation, as well as past the 4.5 hour TPA eligibility window. There were no TPA cases in March, April, or November of 2020, and there were increased delays in door-to-needle time for TPA administration due to PPE and COVID precautions. During this time, there were 4 inpatient stroke alert cases observed in Q4 with concomitant COVID-19 infection. Additional challenges included compliance issues with Joint Commission core measures for stroke patients due to COVID-19 staffing challenges, patients holding an ER for extended periods of time due to bed unavailability, as well as changes in routing to patients for non-stroke units with concomitant COVID-19 diagnosis. There is also shortages with certified stroke RN staffing, as well as initial presentation delays to the ER where there were concomitant COVID-19 symptoms for stroke patients. So all of this really led to an evaluation of our stroke program, as well as expansion of it during 2020. The first expansion included our stroke alert window and expanded that to 24 hours for last known well instead of our 6 hour. This is based on data from the Dawn and Diffuse 3 trials, which were published in 2018, and they really demonstrated a 24-hour thrombectomy intervention window with appropriate radiological findings for patients meeting endovascular criteria. In addition to that, we started working on the expansion of our primary stroke center to be an endovascular intervention capability. This included the onboarding of a neurointerventionalist at Adventist Health White Memorial, as well as certification of a biplane in a new EP lab, as well as initial expansion of our program to include diagnostic procedures such as cerebral and carotid angiography. Some of the lessons that we've learned from all of this as well, and future implications for our program and community, is really the expansion of community education in regards to the safety of medical care provided despite COVID-19, as well as the importance of BFAST education for our community for prompt stroke activation and EMS activation for patients experiencing acute stroke syndromes. This is also an education opportunity for our providers, especially in the ER, in regards to documentation of delays and inclusion and exclusion criteria for stroke measures. This was really an exemplary and incredible opportunity for collaborative effort between nursing and the entire medical team in terms of delegating to provide appropriate stroke care during this surge. as well as, again, expanding our program to include evidence-based practice criteria, as well as guidelines. In an effort to meet the educational needs of our community, we created BFAST education for our patients in-house, including a magnet that each one of them gets to take home in English or Spanish with BFAST symptoms to share with their family members, as well as for quick stroke activation and alertness for those that are at risk for another stroke. In addition to that, we created a community flyer with both cardiac warning signs as well as BFAST warning signs for stroke symptoms, which will be mailed out to our 90033 community to increase awareness about stroke activation and EMS activation for stroke patients. A big thank you to Dr. Liu, who is the director of our stroke program, as well as all of our collaborators and our different stroke teams that provided their data for this write-up. And these are my references. Thank you.
Diana, thank you so much for your presentation. At this time, we are going to go up to Adventist Health Glendale's Family Medicine Residency Program. And again, we wanted to thank the system that's participating. At some point, we would love to make this a system research conference. We've started this about 6 years ago. We've integrated Simi Valley and Glendale, and we're so glad that Glendale's here participating with us today. And again, hopefully in the future, we will get the whole system and we can do this system-wide. So Glendale, take it away.
This is Colleen Mrsa, our third-year graduating resident.
Thank you.
Thank you, Dr. Yu.
Thank you. Okay, hi, yes, as Dr. Yu said, I'm Talin Mrsa, and I will be discussing sustainability of virtual touring in place of in-person touring per this year's residency applicants. So COVID-19 accelerated many changes, affected interviews, standardized testing, rotations, and more, and we continued to acclimate to these changes. The California Residency Network this past year required that all California residencies perform virtual interviews. So we continue to learn through trial and error, given the new set of contact-limited precautions we currently live by. So a little bit of background, obviously the pandemic required us to modify established practices, and touring became virtual for COVID compliance and to reduce exposure potential. So we were required to do virtual interviews with little time to prepare. My co-resident Shirin and I volunteered to help. And as a residency, we wanted to find the best way to represent ourselves accurately so that we match with individuals who would truly be a good fit. After speaking to attendings and residents from other programs, as well as looking into their websites, we asked our own residents what is most important to include on the website to depict our program most realistically. So the feedback was to make it as conversation and personable as possible. In addition to much of the typical program statistics and information residency websites have, we wanted to have a video featuring residents in order to simulate an in-person interview day. We did a resident Q&A, asking the most commonly asked questions we ourselves compiled that we desired to know when we were applicants. The video also had a virtual tour led by a resident and filmed in a way, in such a way that the viewer is getting a first-hand experience of the entire hospital and clinic, often showing residents and attendings in their natural habitat on a typical workday. So a link was provided for the site, which has the video tour, and there was a virtual interview that was done via Zoom. And then a survey was emailed out shortly after completion of interviews, but before match, in hopes that applicants can more easily recall their experience. So the survey, what did it include? There were two components. For research scaled 1 to 5. We asked about satisfaction and superiority. So overall, how satisfied are you with your virtual residency tour of our program? And do you believe that a virtual tour of our facilities is superior to an in-person tour? And then there was also a free text portion of just for future improvements and things we can implement. We asked, what was your favorite part of the entire website? What was your favorite part of the video specifically? And do you have any feedback, on what can be improved on our website? So 100 applicants interviewed, and we obviously sent out the survey to all 100, and we received 31 responses. And as you can see, a majority were either satisfied or very satisfied with their virtual residency tour of our program. But when it came to superiority, a majority of 41.94% strongly believe that virtual touring is inferior to in-person touring. So the survey, favorite part of the website was the resident-to-resident interview, as well as the organization of the website. Things that we could improve on, alumni info, fellowship placements, and they wanted more contact information. I think just multiple avenues of contact. So in conclusion, 27 out of the 31 applicants were somewhat to very satisfied with their experience. 23 out of the 31 believed it was an inferior experience. So there is potential for sustainability if we continue to make it as similar to an in-person experience as possible, whether that means more in-depth videos, clips of each individual resident and attending, virtual social events, things like that. An option may be making the Q&A and the tour live, allowing applicants to interact and ask questions in real time. There are many benefits of keeping the experience virtual for both applicants and the program. It can be a feasible option for those living out of state or who would have to travel long distances. So the virtual platform would most likely increase the volume of applicants and broaden the applicant pool, as cost is a significant factor in consideration in the application process. It would make it possible for those with financial limitations to now apply and interview. However, one thing to consider is that if it is made optional, then there's concern that the applicants that decide to do in-person interviewing may be perceived as having more of an interest in the program. The role of virtual interviewing remains uncertain, but will definitely be considered even beyond the pandemic, whether it's offered as an option or is adopted as the new conventional method of interviewing. So as all studies, ours had limitations. Very few applicants have done in-person interviewing for residency before, unless they applied during prior cycles. To be able to accurately make the comparison, they're using prior in-person touring experience to form a comparison. Despite being anonymous, some applicants may have been hesitant to give criticism or any form of negative feedback in fear of it being traced back to them and harming their chances of acceptance. There are far more ways of assessing sustainability other than satisfaction and superiority, so that's definitely a limitation. It's a small study size of 31, and it's limited to the way a single residency performed virtual touring in its own specific way. And the survey was sent out at the same time. So obviously for those who interviewed earlier, there could be potential for recall bias. That is all. Thank you so much. And I'm open to questions.
Thank you very much for your presentation. I don't see any questions from the audience.
Thank you.
Thank you. So is Dr. Harmson next?
Yes, I am here.
Hi, doctor. Thank you for joining us.
Thank you.
Dr. Harmson is presenting on a proposed model for outpatient treatment of COVID using MAB at a community hospital.
This is a proposed model for outpatient treatment of COVID with monoclonal antibody infusion at a community hospital, that hospital being our hospital here at Adventist Health Glendale. So brief overview of what we're going to be talking about, just the structure of the presentation. So background. If you imagine back in October of 2020, COVID was still rampant. We were just recovering from a huge surge over the summer and obviously spring, that initial surge. We were trying really hard to figure out a way to prevent or at least control the amount of patients that would be coming in. We anticipate the holiday to be, frankly, a nightmare. So without any effective treatments, just some, supportive care, remdesivir, Decadron, we didn't really have too many options. So we're scrambling for a way to try to prevent these admissions and give treatment to patients. So The Blaze-1 trial came out at the end of October, and this is a study performed by Eli Lilly that studied one antibody, bamlanivimab. I can't say it, so BAM is what we're going to call it. And the initial studies or the initial outcomes of that phase 1 of this study was very promising in patients over 65. We actually had significant difference in mortality and morbidity in that population. So there's an emergency use authorization passed by the FDA at that time, and when my hospital really started getting in on this. So we had to devise something fairly quickly to get things going. So I'll talk a little bit about what we did then. So again, the purpose of this presentation is to kind of go through the protocol of delivering this medication to patients and making sure they have adequate outpatient follow-up. The second part of this study, which we're actually pending IRB approval to get our control studies, would be to look and see if we did in fact decrease admissions at our hospital. So for any trial, there are inclusion and exclusion criteria. Obviously, the most obvious one being they had to test positive for COVID-19, but there are other inclusion criteria that we did. So the patient had to be older than 65 years old with a positive COVID-19 test, or they had to be greater than 18 years old with a high-risk condition, as in hypertension, diabetes, being the main ones, any sort of immunosuppression, end-stage renal disease, etc. And they had to be on room air. They could not be on supplemental O2, and they could not meet admission criteria to receive the therapy. Exclusion criteria are stated in addition. So this is just going over, we're in phase 1 right now. We're not started phase 2 just yet. We're still pending IRB approval. So none of our data at this point is controlled. We are asking for data so we can match and control these groups. This is the checklist that our ED physicians use to determine the eligibility of the patient. Just because some are checked off did not mean that they received the drug. But this is what we use to help screen initially patients that may be eligible for this new medication. This required a lot of work. We had basically an isolated section of the emergency room dedicated to these infusions. All of the ED physicians, nurses, and mid-levels were trained to identify this. Pharmacy was involved and make sure that we had the drug. It had to thaw for an hour. Then we had to deliver it to the patient, infuse over an hour, and then monitor them for an hour for any adverse reactions. So what we were tracking, demographics, disease severity, all of these lab markers and vitals are markers of disease severity as we knew at that time. And then any comorbidities they may have, and just making sure that they didn't meet admission criteria before they left the hospital. When they were discharged from the ED, they received these discharge instructions explaining basically the drug, that it's experimental, that they may experience adverse effects, and the ones we really want to know about are listed there. If they had any of those, the phone number for the emergency room was there, and they would receive instructions to go forward from there. Additionally, the information of this patient was transferred to our outpatient clinic. They were scheduled an appointment on post-infusion day 1, day 3, day 7, 11, and 29. And they had a telephone or telehealth encounter with a physician for each of those days, running through their oxygen and their symptoms. Now, each patient also was discharged with a portable pulse ox and taught how to use it and given a logs to check their oxygen 3 times a day. So what did we find? We can't really speak to significance or anything at this point because, as I said, this is uncontrolled, but our preliminary data of the patients that did receive an infusion, we started to see some symptom improvements early as post-infusion day 1, but in general, most of the benefits seem to be between day 5 and day 7, and which we can kind of outline there, and then fewer symptoms, complications, or asymptomatic. So we had 160 patients in total that were infused. We initially thought we only had 38 doses and thought we were only going to infuse 38 people. However, As we started infusing, people caught word. We were the only hospital at the time in California in the area doing this sort of therapy. We started getting donations from other hospitals nearby, and we started offering the Regeneron in addition to BAM. So with that, we had fairly good outcomes. We had 17 hospitalizations, one readmission, which was somebody who was hospitalized, discharged, and then hospitalized again, and then one death. This patient had a GI bleed related to Xarelto. Whether or not it was related to the therapy, we've still yet to say. There's not enough data to say one way or the other. So numbers, preliminary, encouraging, but we can't say too much otherwise. So our next steps are to go through the IRB, get a control group. So we're going to get COVID positive patients that were sent home and track how many times they came back to the ED, where they admitted, and what their outcomes were, and kind of match it according to the comorbidities and the disease severity we've already tracked, and see if there's any significance. Did we actually decrease hospital admissions and help the hospital out that way? So stay tuned. I anticipate that will be done for next year. Acknowledgements. These are our cats. I'd like to thank our CAT teams, the COVID advisory team at Adventist Health Glendale. It's a multidisciplinary team that helped us put all of this together and coordinate all of this. In addition, the family practice staff at Adventist Health Glendale and our clinical staff at the Vituity Family Medicine Center, because I gave them an absurd amount of work for this, and they were fantastic. So, you know, it was a difficult thing to put together, a lot of moving parts, but we were able to get this all set up within 1 week's time. So starting around November 2nd to go live around November 11th. We did a whole lot of work and got this going, and it ran really smoothly for how quickly this went. So good job, you guys. And then our references here.
It was a great presentation. Thank you very much. Very exciting.
Thank you very much.
Good stuff. It's the teamwork that makes the dream work, right?
Exactly.
Yeah, it was a tough time. So thank you for being residents in a really rough time. Hopefully you never have to experience that again in your careers.
Well, thank you.
Our next presenter, I believe, is Dr. Sahagian. No, we got clapping. Advancement of longitudinal chemical dependency training for a family medicine residency program. Take it away.
Thank you. Hi. Okay, give me 1 second. Let me just open this up. Okay. All right. So yes, I'm Anita. I'm a second-year resident. So today I'm going to cover basically how our program advanced our curriculum for substance use management. We did this because we targeted this area of medicine because it tends to be overlooked. There's a large majority of physicians that aren't really familiar with this area, and that in the end tends to really limit the resources for our patients when they're looking for management. So in order to do this, we had multiple different goals. One was obviously to work on the education portion for our residents, but also to be able to apply that when we're in our clinic. And that meant creating protocols that could be easy to use and accessible. And then lastly, we also wanted to be able to provide more resources for our hospital staff and then patients that would come into the hospital. So this project was supported by a grant that we were able to obtain from the CFP. So they provided the funding, but also a really great network for us by allowing us to attend like in-person conferences and then later on Zoom conferences to brainstorm, do group activities, and even just ask questions. It's a great support system because there are other programs around the state that had the same goal in mind for their own programs as well. And so the first thing that we did, we wanted to target the training portion for our residents and our faculty. We wanted to figure out why we had such low numbers when it came to completing medication-assisted treatment waiver training. So looking at the different reasons, doing a root cause analysis, we were able to determine that, well, basically there just wasn't enough time for our residents to do an 8-hour-long course. And it wasn't strictly enforced as well. And a lot of residents and faculty didn't really understand why it was so important. So we implemented a plan, do, study, act type cycle where we provided the resources, which was the training for a patient to be able to get the certificate, or sorry, the resident or the faculty to get the certificate, and eventually apply for a data waiver so they could actually prescribe buprenorphine or Suboxone. So just as an overview of what we did, for our baseline around June of 2019, we had only about 40% of our program that had completed the training. This only included one faculty member, our advisor, and 2 second-year residents, and then third years that are about ready to graduate at that time. During the first cycle, which was 3 months long, it included all the incoming PGY1s, as well as the PGY2s that were doing their substance use rotation. So we really just enforced completion of the training a bit more, but still didn't have a lot of time for them. By the end of the 3 months, we had about 66% completion, but that obviously still wasn't enough. So looking at the second portion of the 3 months, we continued to send out reminders, emails, hoping to get everyone to complete the training. So by then we had all faculty completing their training, and majority of residents except for about 4. So that was 88%. So our goal for this was basically to set aside an allotted time for all of our interns to complete the training during the orientation. That way we would get 100% completion rate of the training. So then looking at our hospital and then community, we wanted to provide more resources for our patients. And one way we wanted to do this was to provide Narcan. So via the grant, we were able to obtain about 500 Narcan boxes, place them in a locked cabinet in the ED, so that any provider or staff could provide this Narcan to any patient or family member that required it, and then to educate them at the same time as to why it's so important to have as well. Unfortunately, just because of the timing, we did run into a few barriers, including COVID. Staff awareness as well was a bit of an issue, and then there was a bit of hesitancy as well. So it is a work in progress. We still have these resources available in the ED, and we're continuing to work with the ED physicians and all other nurses, staff members to just provide more awareness. And we also have Narcan available in our residency clinic as well. Then moving on to how we could apply this knowledge to our continuity patients or clinic patients, we were able to create a treatment protocol for patients that wanted to start Suboxone or buprenorphine for opioid use management. And just as an overview of what we did, as far as what is included in the treatment protocol, we usually start off with an initial visit where we obtain a history and physical, do labs, urine drug screens, and just a psychosocial assessment to see if they're able to or qualify to start induction. And if so, we set them up. They'll either come in for an in-office induction or they can do it at home. The in-office is usually 3 to 4 hours long, and we observe the patient when they take their first dose, and we see how they respond. And based off that, we're able to manage their dose and what we feel would be safe for them. After that, we'll have maintenance visits where we'll provide counseling, we'll adjust their dose as necessary, and we'll also do random urine drug screens for them as well. And if a patient feels like they're ready to stop buprenorphine or Suboxone, we also have a tapering protocol available as well. And all of this is available on our Basecamp site, which is our main communication portal for all our residents and faculty. And then overall, throughout the year, we did want to continue education for not just for our residents, but also for all of the hospital staff. We wanted to make this as broad and wide as possible and available to anyone. So we did have a couple of continuing medical education, pharmacy education lectures that anyone could attend. And our goal is to continue that on during this year. And then, so just going on to the future, what our plans are. Obviously, we want to get more staff involved, all different professions, including pharmacists, nurses, social work as well. We do have an opioid stewardship committee that was set up during this time. So we are actively working with multiple different professions in the hospital currently. In addition to that, we wanted to just continue to provide more training, education throughout the year so we can reinforce this type of management for our patients. We start off with doing the waiver training that now has a lot of time during our intern orientation. We'll do further CMEs and CPEs, and then currently we're participating in a longitudinal pilot curriculum that's led by the Society of Teachers of Family Medicine. It's a 12-month program. We cover 12 topics, one topic each month, and usually we'll do it during our own noon lectures. And so that all our residents have the opportunity to attend that. Yeah. And that's it. So thank you. Okay.
I love the cheering section at Glendale.
They're very, very helpful, very helpful.
So our final presentation of the day, and I'm going to thank again everybody from the system that was able to join us today and all of the residencies that participated and all the work that you do. We're really grateful that Glendale has joined us this year, and we look forward to your participation next year. And the closing speakers of the day are Dr. Tarosian and Dr. Leo. The effect of ethnicity, glycemic status on cesarean sections, and instrumented delivery rate on nulliparous singleton vertex term deliveries.
Hi, everybody. I'm Narek, one of the third-year family medicine residents from Glendale. Our presentation, I worked on it with Dr. Jonathan Leal Mendoza, one of my co-residents, Dr. Yu, and we also got some assistance from Dr. Yu's daughter with some of the statistical analysis, Lisa and Yu. So starting off, intro. So the effect of obesity, gestational diabetes on OB outcomes is well established, but there's an unclear effect on certain ethnicities and hyperglycemia on these outcomes. At Adventist Health Glendale, we had the third highest C-section rate in California in 2016. As part of our training, we need to complete a certain number of vaginal deliveries. And in general, patients prefer these sorts of deliveries versus C-sections or instrumented deliveries due to the association between morbidity with those. These are the C-section rates for various local hospitals. Adventist Health is 27.1, White Memorial is 25.9, and we're both above California state average. Our hypothesis was that Asian ethnicity compared with Hispanic and white ethnicity, hyperglycemia and gestational diabetes both all increase C-section rates, instrumented delivery, third and fourth degree laceration rates, as well as shoulder dystocia rates in NSVT patients. We established this hypothesis as one of the aspects was the World Health Organization defines overweight and obesity at a lower threshold for the Asian population, as you can see, versus the non-Asian population. So our methods, it was a retrospective case control study. We got data from our EMR at Adventist Health Glendale from 2012 to 2021 with statistical analysis using Python, and we excluded multiparous patients and then patients with missing and incomplete data. So we started off with around 900 patients total, and we whittled it down all the way down to around 369. So about 2/3 of our cohort were Asian, around a quarter Hispanic, and the rest were of white ethnicity. More granular, our Asian population, around 50%, a little over 50% was Thai, and then Filipino, Cambodian, Japanese, approximately 12 to 14% each. And then we had a little bit of other Asian ethnicities in there as well. So from what we see, the delivery breakdown, we have around 15% vacuum assisted deliveries versus 9.5% for Adventist Health Glendale. The 15% would be just the family medicine program. And then around a 5.2% rate of vaginal deliveries ending up in third to fourth degree lacerations for the FM program versus the hospital rate in general. We see that in the Asian population, there was a higher C-section and vacuum-assisted delivery rates compared to the other ethnicities. a trend that we noticed in terms of delivery mode was that primary C-sections and vacuum-assisted delivery babies had a higher birth weight. The moms tended to be older, and they had a higher average 1-hour glucose test. This is just another variant of that, basically. Moving on here, in terms of by ethnicities, the Asian population had a smaller average pre-pregnancy weight, baby weight. However, they had an increased maternal age and a higher percentage of hyperglycemic and diabetic patients. We see that increasing maternal age was associated with more primary C-sections and instrumented delivery rate, as well as shoulder dystocia. In terms of age and ethnicity, the Asian mothers in our study tended to be older on average. So we see that with our cohort, the higher the pre-pregnancy BMI, the baby weight, and the maternal age, the increase in amount of primary C-sections, instrumented deliveries, and 3rd to 4th degree lacerations with the NSVDs. In our Asian population, we saw that the hyperglycemia and gestational diabetes increased the C-section and instrumented delivery rates. Hyperglycemic patients, we noticed, had higher rates of primary C-sections and assisted deliveries, or sorry, instrumented assisted deliveries. And we believe that this is because those that were formally diagnosed with gestational diabetes would regularly check their blood sugars and would kind of be on top of their blood sugar control, and they would actually try to control it, whereas those that were just diagnosed with hyperglycemia weren't really followed up as closely. Now, there's not necessarily enough data for this point, but there was an increase in primary C-sections and 3 to 4th degree lacerations in Asians with pre-pregnancy BMI above 27. So we see that with this slide, that less weight gain was associated with a lower primary C-section or increased instrument and a less percentage of instrumented assisted delivery, except for whatever reason, we had more instrumented deliveries in the Hispanic population that had less than 25% weight gain. Now, ACOG recommends 25 to 35 pounds gain throughout pregnancy for a normal BMI, but the less is better. So even with normal pre-pregnancy BMI, increased weight gain led to more C-sections in our study. In terms of study limitation, we had a limited number of patients, around 370 or so. We only studied patients from our hospital. Different physicians at the hospital had different C-section thresholds. The ethnicity that we obtained was either self-reported or based on Google searches of the patient's last names. Now, I think the study can be expanded with inclusion of, for example, the Adventist Health White Memorial Chinese population, which is much larger than our Chinese population, can give us more information. In terms of summarizing our data, we see that Asians had a higher percentage of non-normal spontaneous vaginal deliveries, but on average, this was not on the rise. Asian mothers tended to be older, had smaller babies, and had a higher rate of hyperglycemia and gestational diabetes. All the delivery modes in terms of NSVD versus instrumented assisted deliveries versus primary C-sections were similar, except for in the older mothers, they were more likely to get primary C-sections. So again, Asian women had a higher risk of hyperglycemia and gestational diabetes. The instrumented assisted deliveries and the 3 to 4th degree laceration rates were higher in the Asian population and associated with older age and increased hyperglycemia and gestational diabetes rates. Possible causes is where we believe may be due to the older age of these mothers, cephalopelvic disproportion from a smaller Asian pelvis, and then sort of like the diet in the US, where we have increased food intake and carbohydrate intake, leading to hyperglycemia in bigger babies, and possibly increased glucose intolerance in Asians. So our recommendations would be trying to decrease the age of childbirth, although that can be difficult, and decreasing pre-pregnancy BMI and diabetes and hyperglycemia by limiting diet and weight gain throughout pregnancy. And this can be facilitated with increasing physician awareness of ethnic differences in BMI, the different thresholds that we talked about, and probably being a little bit more aggressive in managing pre-pregnant BMI and weight gain in the Asian population. And that ends the presentation. Thank you, everybody.
Thank you, Doctor. Appreciate your presentation and your participation. So on behalf of Adventist Health White Memorial, who's hosted this 6th annual research symposium, we wish you the best and thank you for joining us, and we'll see you next year. Thank you.